All right. Good morning, everyone. I think thank you for coming. This is a challenging day for travel. I, for one, when I was backing out of my driveway, there was a snowplow just putting out a pile of snow at the end. So I really appreciate everyone who's made it here. And I also want to welcome and thank you for all of those people you are watching online. Thank you for being with us today. And we're very excited to have you with us today. And we have a great lineup of speakers today for you. And I just want to have a couple of housekeeping announcements for everyone. The bathrooms are just outside this auditorium back there. And we have so many people coming today. And I was told about 75 to 100 people are still searching for parking. So they're going to start filing in continuously while we talk. And I hope they will just find wherever there is the closest seat. And then for those of us who have already sat down, just give them a little bit of help so that they could sit down quickly. All right. So my name is Qiang Chang. I am the director of the Weizmann Center. Very proud of this place, and 600 staff come to work here every day. Investigators, clinicians, graduate students, postdocs, and trainees to help improve the quality of life of those affected by a wide range of neurological conditions, and to a wide range of activities, research, service, outreach, training, education here, and really inspirational place to work because of the impactful stuff happening here. I hope that's why you're here today, and I'm going to give you a quick overview of the center, and then we'll start the speakers. Really, here at the Weizmann Center, our mission is to advance knowledge on human development, neurodevelopmental disabilities, and neurodegenerative diseases. And just a quick definition, what is a neurodevelopmental disability? Basically, the onset is prenatal, it's early, and it really affects a child's life in many aspects, and it is a life span disease. It's not just that you have it early on and it goes away. It stays with the individual, and you can see that it affects the life of that individual and his or her families for a long, long time. And examples, prime example, autism. That's why we're here today, the topic of today. And there's other pretty well-known conditions as well, such as Down syndrome, Fragile X, cerebral palsy, and many others. And for neurodegenerative diseases, these are conditions that are manifesting different from developmental disorders. These can happen anytime in life. It could be early, it could be late. It's not restricted to early. In many cases, these happen quite late. And of course, once it shows, it will continue affecting the individual's life thereon, and it again affects the person's life in many different ways. Also, as you can see, the families as well. And in many of these cases, they are progressive, and the prime examples are, I'm sure many of you know, Alzheimer's disease, Parkinson's, ALS, and many others. And the reason we have both neurodevelopmental and degenerative diseases on our plate here at the Weizmann Center is that at the molecular and cellular level, at some levels, underlying biology, these diseases, these two large categories of diseases, have commonality. Even though they manifest at different time point during a life, an individual's life, and they have different presentations, clinical presentations. If you drill down to the deeper mechanistic level, often they share common pathways, common molecular players, and by studying one type, once you better understand the mechanism, actually informs our understanding of a more broader spectrum of conditions and into even the other categories. So that's why we are interested in studying both here at the Weizmann Center. And this is really a prime example of multidisciplinary work. And as you can see on the slide, we have a wide range of activities, as I mentioned. We have research, we have service, we have training, we have outreach. And in each of the category is also multidisciplinary. Just to look at the research side of this center, really a wide range of research activities in the labs of 50, 60 investigators, and using approaches ranging from molecules in a test tube to doing neurobehavior analyses in individuals, or doing brain imaging scans in people, and everything in between. And that is not just the approach, but also the topics being studied here. We have people who are interested in how infants learn language, how to speak. We have people who are interested in studying emotional development in adolescents. We have people who studied in motor functions in autism conditions, and on and on. So many different ways and topics here in the center. That forms a strong foundation for making fundamental discoveries, and later in turn will benefit in service in terms of clinical diagnosis and treatment. And we have multiple examples where research here, primary research happening in Weizmann Center investigators' lab, really got to the point that either being developed as therapeutics for neurodevelopmental diseases, or already offered in clinics here at the Weizmann Center. Many of you probably are aware of the autism treatment program here at the Weizmann Center. One of the behavior intervention offered in the center, the transitional together technique method, is developed here by Leanne Smith, our director for USAID, when she was doing research in Marsha Mavick's lab here at the center. So really, the unique strengths of the center is the collaboration and integration across these range of activities. There's wide-ranging collaboration between clinicians in the clinics and researchers in the lab. The Alzheimer research in Down syndrome, a national cohort study, is another prime example of strong collaboration between physicians and researchers, and researchers from multiple disciplinaries within the center. So really, the integration across these activities adds value to every individual activities. And so, as you can see, our goals really are to first understand the causes of these conditions we're interested in that impact people's life, and also to understand the consequences, sort of the mechanisms of these conditions, and then looking for really treatment and cure for these conditions through basic translational research and clinical research here at the center. Who we are, I hope I have given you some background on the center, but really to better understand who we are, many times we reflect on the history of the center and how we started, and that really have had a long-lasting impact on who we are and what we do today. We're named after Dr. Harry Weizmann, Weizmann Center, and he is trained here at Wisconsin. All of his degrees, bachelor's, medical, and PhD, are here from Wisconsin, Madison. And he himself is a pediatrician treating diagnosing and helping individuals affected by PKU. And he is also a biochemist who has a research lab here studying the mechanisms underlying this devastating condition. If that's not enough for a physician scientist, he was also a strong advocate for individuals affected by the condition, as well as a broad range of developmental disabilities. He served on the national committee convened by JFK, John F. Kennedy, and that's the commission that sort of came up with the recommendation of establishing a national institute focusing on child development and starting an impactful national funding and research program to develop across the country infrastructures for studying and doing research and providing service for individuals affected by those conditions. So he also was someone who advocated for prenatal testing, and for his disease of interest, PKU, it's a condition where you get a drop of blood when the babies are born, and you can test whether the person is at risk of that, and then the further testing can confirm and give you a diagnosis. And if you take a modified diet from that point on, then you would not develop any of those devastating symptoms during development and later in life. So really, testing, prenatal testing, it has been expanded to include many other conditions, and is a very impactful tool in promoting public health. And he, as you can see, he did research, he provided clinical service, and he did outreach in the most impactful way, and then of course he trained many trainees as well. So he is the example of what we are doing today, and we remember him not only by name, but by practicing what he successfully practiced during his life. And so we are here at the Weizmann Center, as you can see on the map. One of the centers, the oldest centers receiving national funding from National Institute of Health to first establish and then continue developing strong research infrastructures focusing on the understanding of these devastating neurological conditions. And you can see strategically we're located in an area where it's really sparse, and on the East Coast you have many of these centers, but in the middle you don't have a lot. So our geographic location is really very important. And we are, as far as I know, the only center that has 3 major federally funded programs, all focusing on the neural development, intellectual and developmental disabilities. And that includes the IDDRC, Intellectual and Developmental Disability Research Center. This is a research arm, UCET, University Center of Excellence in Developmental Disabilities, and that's the service arm, training arm as well. Outreach, and LEND is another independent program here at Weizmann. It is under UCET. It's a training program, wide-ranging training program, focusing on IDD, and it trains not just your typical graduate student postdoc. It includes community workers, social workers, patient advocates, genetic counselors, developmental pediatricians, a wide range of professionals who have impact on this IDD community. And as I mentioned earlier, a large number of investigators from many academic departments across the campus have their labs physically located here at the Weizmann Center, and we're a unit under the Office of Vice Chancellor for Research and Graduate Education. That's the office in charge of the entire research enterprise across campus. And just some numbers here, as you can see, our reach and impact. Over 9,000 patients visited and was seen here at the Weizmann Center last year. And we have many, in addition to those federally funded center programs, we have individual research grants from NIH to support the activities here at the center. And as you can see, our work doesn't just stop in the labs, in the clinics, and in the community. We even have, in the broadest sense of education, we have an early childhood program. And the unique feature of this is that we have a large number of slots in the program that's reserved for children with special needs. And we are trying our best to continue tradition as the national model for inclusive early childhood education. And we have served many, many children over the years. And by the way, this was initially the vision of Harry Weisman. He wanted a school here. He envisioned that they would not only need treatment, they also needed to be educated and then have a life in the community. So he designed a school. And due to federal law changes, the segregation cannot be continued. So you have to mix people affected by the conditions, special needs children with typically developing children. So the school stopped functioning that way, and we converted into a daycare later on. But nonetheless, it was we have Harry Weisman to thank for, even for the existence of a preschool program here at Weisman Center. And we have many, many tertiary specialty clinics here in the center. The one with probably the most number of patients served or individuals served is the Autism and Developmental Disability clinics. And you can see there are genetics clinics and a wide range of other clinics here at the center focusing on IDD. As I mentioned earlier, our work here in the clinics does not stop at diagnostics. When possible, when there is a research to support evidence-based treatment, we provide that. And this is the autism treatment program here at the center, and they work closely with the diagnostic clinic here at the Weisman Center, and it's a continuum. That's the way we view it. I mentioned some of the key intervention schemes offered in the autism treatment program here, and highlighting the Together program developed here by Leanne Smith at the Weisman Center. And just to highlight a few of these, so I've touched on research, clinical service, training so far, and just to highlight some of the outreach work we do here at the center. The Grandparents Network is really a fantastic network providing support to these grandparents who have individuals affected by IDD in their family. And this is a monthly program. It's very well attended for. I've been there a couple of times. It's really fun to interact with these individuals, and they are really strong supporters of the center. And we want to, through these type of regular dialogues with the community, share the events or knowledge we learn as it goes here at the center, and help to support their lives and improve the quality. And this is another very impactful outreach program here at the Weisman Center, the Day with the Experts. This is where we, again, share the knowledges we learn in research, and also share the best practices we know in our clinical practices with the community, so that they can benefit from the work we do here at the Weisman Center. It's really a very strong connection between the center and the community, as evidenced by all of you sitting here in the room and the people who are watching online. So thank you so much for being with us today, and I'm of course happy to answer any questions you may have, the burning questions, if there's any. Okay, seems to be quite clear. So without further ado, we'll have our speakers. I don't have a program here. Oh, I have one here. Our first speaker is Danielle Schultz, who is going to talk about anxiety on the spectrum. Thank you.
Well, thank you everyone for being here. My name is Danielle Schultz. I'm one of the developmental behavioral pediatricians, and I work pretty much all the time in the Autism and Developmental Disabilities Clinic here at the Weisman Center. And I'm going to be presenting along with another person, so I'm going to let her introduce herself.
Hi, my name is Martha Walter, and I'm a psychologist here at the Weisman Center. I'm in a few different clinics, including the Autism and Developmental Disabilities Clinic and Down Syndrome Clinic, as well as on a research project. And so we are very happy to be here today talking about anxiety and autism. So during our presentation today, we will plan to talk a little bit about anxiety, about how anxiety disorders are diagnosed. We'll talk about the overlap of anxiety and autism, and then both behavioral approaches to managing anxiety as well as medication in the management of anxiety and anxiety disorders. So first, we'd like to talk just a few minutes about anxiety and what this might look like. One way that we can understand anxiety is that when there is a true danger, so something like a fire, someone breaking into your car or home, a large animal approaching, a type of alarm goes off in our bodies. This is a good thing because it helps our bodies get ready to handle the situation. It's that flight or fight response. However, some people have overactive or false alarms. So alarms in which their bodies may more frequently have these types of responses to different kinds of situations. For example, if your body's alarm goes off when a car drives by, rather than having it go off when someone's breaking into your car. And this can be a problem because our bodies are sort of tricking us into thinking that there are these true dangers when there may not be. Experiencing anxiety occasionally is a normal part of life. And as I mentioned, this can be helpful and adaptive because we have to be able to respond quickly and efficiently when there is a true danger or crisis. Anxiety becomes a disorder when a few different things are true. So one is if the anxiety is really significant and persistent over time, so not a typical reaction to sort of a frightening event, but instead really significant over-response to events, or anxiety that may be more constant and generalized across many, many different settings and is not necessarily a response to a specific trigger. Anxiety disorders also involve a number of different kinds of symptoms, which we'll talk about in a moment. And finally, the anxiety, to be a disorder, must cause significant impact or suffering in someone's life. This last point is important. Many people are anxious part of the time to some degree, but for the anxiety to be considered a disorder, it must interfere significantly with daily life or day-to-day activities. So this slide shows some of the different symptoms we can see with anxiety, and in part, it can be the presence of these symptoms that help to differentiate anxiety from a typical reaction to stress versus anxiety disorders. So a number of different physical symptoms such as increased heart rate, breathing rapidly, sweating or feeling weak or tired, and then other types of things such as trouble concentrating or sleeping, feeling nervous or restless or tense, having difficulty controlling the worry. So the current system or manual we use for understanding the different kinds of anxiety and making diagnoses of anxiety disorders is the Diagnostic, and it's a mouthful, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5. And there are a number of different kinds of anxiety or ways that anxiety can present in individuals. here's a few of them, and we won't go over them in detail today, but things like generalized anxiety, separation anxiety, selective mutism, and so forth. It is really important, it's important to know that there are these different kinds of anxiety, but it's very important to understand which type or types of anxiety someone may have, because this can really have a big impact on the treatment that would be most helpful and beneficial for them.
So the question of whether anxiety or anxiety disorders is more common in people with autism, many people think wouldn't be that difficult to answer, but it has proved to be really difficult to figure out. So there is an overarching, when you look at lots of different research studies, there is a belief that anxiety is more common in people on the spectrum. However, how common it is and why that is still really widely unknown. So the estimates of kind of people on the spectrum who have anxiety range anywhere from 10% to 80%. So it's a huge range. Doesn't really help us a whole lot. Most people believe that is around 40% is a more accurate estimate. And if you think about 40% in people with autism versus about a little bit less than 20% in the general population. So that's about twice as frequent as people in the general population who don't have autism. There are a few things that tend to predispose people with autism to being more likely to have anxiety. One of that is having a higher IQ. So higher IQs, higher cognitive functioning has been associated with an increased risk of anxiety. That being said, there's a question as to why that is. Is that an underlying issue? Is that because they're better able to verbalize anxiety and express that, which is probably a big part of it? And also, are they better able to maybe realize some of the things that are going on around them that could trigger anxiety? So there's a lot of different things that go into that. The other time that it's been seen that there's a significant increase in anxiety, I think in the general population, but as well specifically in people with autism, is during adolescence, especially in girls on the spectrum during adolescence. It's much more common to have anxiety in that group, and I think we can all understand why that would be. Another common time when anxiety tends to increase is also during transition, especially late in adolescence, early adulthood, when people are transitioning out into the community and there's just a lot of unknowns out there. So, what does anxiety look like in people on the autism spectrum? Well, first of all, it oftentimes looks exactly like everybody else, so it doesn't mean that it looks specifically different. But there are definitely characteristics that can be different and more noticeable in people on the autism spectrum who have anxiety. So obviously those physical features and those physical symptoms of increased heart rate and all that are still about pretty much the same. Those still occur. But very frequently it can cause emotional lability, so a lot of mood swings and moodiness. Behavioral challenges is a really common kind of symptom of anxiety in people on the spectrum. So aggression, anger, increases in self-injurious behavior and things like that. Inappropriate emotional responses, so laughing in at really odd times, or just having a reaction to their environment that doesn't seem to make sense, can actually also be associated with anxiety. Withdrawal and refusal to participate is really common. This is especially an issue in school. So when kids are in school and there's pressure put on them and they get anxious, oftentimes they shut down. Unfortunately, sometimes people see that as, you know, being defiant and difficult, but really it's that anxiety just shutting them down and them having a hard time dealing with that. So it's an important thing to keep in mind. Depression and depression symptoms can also be very frequently seen. And finally, sleep difficulties. Sleep definitely in the general population is associated with anxiety, but definitely more as well in the autism community. So is it anxiety or is it autism, or how do we figure that out? And that, again, is a really complicated question. The first thing I always like to point out is anxiety is not a core symptom of autism. So everybody who has autism does not have anxiety. You don't have to have anxiety to have autism, but we do definitely see it pretty frequently. So how do we determine, oh, well, this behavior might be more just kind of based off of the autism and a characteristic of autism, and when does that cross over into anxiety? And that can be really challenging to determine. One really big way that we determine that is by looking at baseline functioning, baseline presentation, and looking for changes in that. So are there big changes? You know, last year didn't see this behavior. Now this year at school, everything is kind of ramped up, and now we're having a lot more difficulty with refusal or things like that. Specific irrational fears, so really severe fears and kind of that phobia, those are typically really true anxiety disorders. Symptoms that worsen in response to environmental factors, so definitely transitions can be challenging for all people on the spectrum, but definitely kind of really significant behaviors with behavioral challenges with like school return, also trauma. And I like to point out that trauma doesn't necessarily mean like a really big major trauma. It can be something small that a person may feel very overwhelmed by. So it doesn't necessarily mean it was a car accident or abuse or something in that nature. It could be something little that you don't even realize was traumatic to that person. So it's just really important to be cognizant that that doesn't necessarily have to be a big event. And then finally, that the symptoms respond to treatment for anxiety. So sometimes we just can't figure out, is this anxiety? Is there something else going on? And when that happens, sometimes we do try treatment and see how it goes. And if it does improve symptoms, then it probably was anxiety. And if it doesn't improve, then we can stop that treatment and then look for other reasons for that. So, if you think, so by the way, I'm a pediatrician, so a lot of this is my child, but this also goes for adults and yourselves. So if I think my child has anxiety, like what do you do? And I think that's always a really hard a question, because it's like, well, where do I go? Who do I ask about it? The first thing to do is just keep track of it. Look at the symptoms. What do you see? What are the behaviors you're noticing? What are triggers? What things seem to bring that out? And when and where do those things happen? Because that can really help us determine how we treat it. Discuss it with other people who are around your child, so teachers, other caregivers, family members, anybody that spends time with that child. Figure out, like, are they seeing this? Is this some other behaviors that they're noticing in their environments as well? And then finally, talk to your child's doctor, or if you're an adult, talk to your own doctor. I always recommend that when you're going in to talk about anxiety or other more like mental health concerns, let the doctor's office know, because very frequently you're going to need more time. I mean, these are not things that are going to be a 5-minute in and out. So definitely let them know ahead of time that you have these types of concerns, so that they can slot more time for you, and also plan on maybe having that be a longer appointment. And then finally, oftentimes they'll ask you to fill out, paperwork or forms, or you may need to be referred to another provider to get that diagnostic evaluation completed. So don't go into that appointment expecting to come out with an answer. Oftentimes it takes a little bit of time to sort out what's going on.
That's a perfect segue. So if you are referred for an evaluation for anxiety for yourself, for a loved one, or if you are seeking that evaluation out yourself, there's a few places this can happen. So it could happen with your primary care provider or pediatrician if it's your child, but it may also happen with a psychiatrist or with a mental health provider, such as a psychologist. And the components, or specifically what will take place during an evaluation for anxiety, may vary to some degree, but in general will include an interview with the individual, and then with the parent if it's for your child, an informal observation with the individual who's experiencing anxiety, information from other people who know the person, so that might be school providers or other individuals, and then often rating forms that are completed by the individual who's experiencing anxiety, depending on their age, and then by people who know them well. So that could be, depending on the person, parents or school providers or others. So today we'll be talking both about some behavioral interventions or strategies for managing anxiety, as well as some medication options. And so we'll start with some of the behavioral approaches, the most common of which is called cognitive behavioral therapy, or CBT. So CBT is highly structured and has a strong evidence base for targeting symptoms of anxiety. And CBT does this by really helping the individual to become aware of their anxiety and their different emotional states, so that they can implement some strategies to help manage it. CBT teaches individuals a number of different things to recognize different physical, cognitive, and behavioral ways that anxiety manifests, to identify different triggers for anxiety, and to use a combination of different kinds of strategies to be able to manage their anxiety. These strategies can include physical strategies like learning different relaxation strategies. It can include cognitive strategies like problem solving and identifying our thought patterns and trying to make changes to those thought patterns if that's part of what's driving the anxiety. And then it can also include behavioral components. So in a supported way, having experiences to have exposure to whatever that feared situation is. So generally in CBT, the therapist will work with the individual to give information about anxiety, how anxiety disorders develop and how they're treated, and then they work together to understand for that specific person, what are the situations that tend to make them most anxious, what are their specific triggers, and then work together to change some of those thoughts that may be contributing to anxiety, manage their anxiety feelings, and face their fears. Often this occurs in a one-to-one setting, but there are some great group programs available as well, depending on your area and what you're able to access. The other thing it's helpful to do is think about what are the other services or treatments or therapies or supports that the individual has in their life, and how might we think about modifying or optimizing those to have the greatest impact. The other thing that's so important and helpful is just that everyone on that person's team is communicating so that they have a good understanding of what's going on and can use consistent strategies across settings. So if you have someone in your life, such as a child, but it could be someone else who's experiencing anxiety, there's a few things that can be helpful to do. So generally, helpful strategies for helping someone deal with anxiety can be communicating your empathy in an effective way, modeling that brave behavior, because we all go through things that are hard and stressful, and so we can model kind of how might I handle that situation, what strategies could I use when I'm dealing with that. Trying to prevent avoidance of whatever the feared situation is, helping them remember to use those coping strategies that they're learning, and kind of reinforcing when they do use those strategies. Strategies that tend not to be helpful are excessive reassurance, being too directive or impatient, or kind of permitting or encouraging, completely avoiding whatever those fears are. A few other things that can be helpful if you're working with someone either at home or at school or in another setting who's experiencing anxiety can be like a number of different things. Having an organized and predictable routine at home or in the classroom can be really helpful. Preparing for transitions by letting someone know what's about to happen, why is it happening, and what can you expect that we're going to be doing next. Things like trying to dispel those myths or misconceptions about certain events by giving accurate information. Helping them remember, hey, you did so amazing when you did this thing last time, and remember how you used X, Y, or Z to help deal with that situation, and you successfully handled it. Visual supports can be really, really helpful, both to understand the person's anxiety, like a feelings thermometer where you can keep track of how it's going over time, as well as supports to make things more concrete. And then using positive self-talk, like I did this before, I can do it again, and just normalizing and modeling those things too.
So I'm going to move on and talk a little bit about medications. I wanted to start off with just a really brief discussion about medications and autism in general, just so that everybody is kind of on the same page. The first thing I always want everybody to know is there are no medications that treat core symptoms of autism. So there are no medications that treat kind of social challenges or repetitive behaviors or restricted interests. The medications that we do use are focused on treating co-occurring conditions like anxiety or ADHD or aggression and things like that. When we're thinking about medications, the first thing is to figure out what are we targeting for symptoms and how is that affecting the person's life. So when we're thinking about medications, we want to look at a medication that is going to help with symptoms that are actually impacting the function on a day-to-day basis. We want to always think about benefits and risks. What are the alternatives? What other things can we use before going to medications? What are side effects and adverse reactions? The response of medications is extremely variable from person to person, especially in people on the spectrum. What we know is that medication use, when we do use medications in people with autism, we tend to find an increased risk of side effects, and they don't tend to work quite as well as in the general population. So that can be really frustrating for families and for people who are trying to use these medications to improve. It may take a lot of medications before you find the right one. The last thing is probably the most important point, and medications should not be used alone. They should always be used in conjunction with other interventions. So behavioral interventions, educational, psychological treatments, they should always be in conjunction with other things. We should not be relying only on medications alone. I'm going to talk really briefly about this because I want to move on to a little bit more stuff before we run out of time. But when you think about medications, especially in children, there are very few medications that are approved by the FDA for use in children. Anxiety, there are actually none that are approved for anxiety in children. There's some that, but they are approved for other conditions. So that's kind of where we extrapolate the information that we use. There's very limited studies in children and even fewer studies in kids with autism. So when we look at treating anxiety, by far, the most common medication that we use is selective serotonin reuptake inhibitors, or SSRIs, and many people have heard of these: fluoxetine or Prozac, sertraline or Zoloft, paroxetine or Paxil, and there's several other ones. They are used to treat anxiety and depression, so they can be good for both of those things. Benefits can be seen in a week or two, but typically it takes more like 6 to 8 weeks to really see the full benefits of these medications. Which of these medications a provider decides to use can be, it depends on a lot of factors. So it can be provider preference. So for example, I may have a lot more experience with one certain medication. Age has a lot to do with it. So there are definitely some of these medications that have been much better studied in younger kids versus older kids. Also FDA indications. So some of them are actually indicated for older kids versus younger. The method of administration. So can you swallow a pill? Do you need liquid? Any co-occurring symptoms, and then finally family history. And I always strongly recommend, if you have a family history of anxiety and you take a medication that works really well for you, let the provider know that, because we definitely take that into consideration, and I tend to preferentially choose medications that work better for family members first, because it's more likely that it's going to work better in the individual that I'm trying to treat as well. So side effects of SSRIs, usually they're pretty well tolerated, but like I said again, people on the autism spectrum are more likely to have side effects, unfortunately. Common side effects are dry mouth, nausea, diarrhea. A lot of times people will complain about diarrhea early on. That usually does get better, so that's good. Headaches. Some people become pretty drowsy and tired on SSRIs. On the flip side, though, there is a group of people who become activated, and they almost become kind of really wired and hyper, and that can be a huge problem, especially in people on the autism spectrum. So it's kind of weird that you have this kind of differing reactions, so it's not, we aren't able to predict who's going to have those reactions, but it's one of the reasons we like to start medications at a low dose. Insomnia can occur as well. And then finally, sexual side effects, which I think a lot of people don't talk about, but decreased libido, decreased sexual arousal can definitely happen with these, and then sometimes that's really problematic, and other times it can actually be beneficial for some people in certain situations. So it's just something to keep in mind that people forget to ask about. There are black box warnings on all of these medications, as well as a lot of other medications that are used for different psychological conditions. And what that black box warning is that there was an association with increased suicidal ideations in children and young adults who are on these medications. It's really hard to tell what this means. So it was a very tiny percentage of the people who had this occur, but there was a very small increase. And so the reason that we make sure everybody knows that is we want you to think about that. We want you to talk about that. It's very rare, but you want to be cognizant of it. And if it does come up, you want to be aware of it and you want to address it right away. Follow-up, you want to follow up with a provider on a regular basis. We want to look at how effective it is, whether we need to make dose adjustments, look for side effects, especially, like I said, you should be asked every time you go in for a follow-up about suicidal ideations or behaviors. And then finally, these are medications that if you're going to stop them, they should be tapered. Don't just cold turkey stop them. You should be tapering them with the advice of a physician. There are several other medications that can be used for anxiety, but I will tell you they are typically not used very often. So the TCAs or tricyclic antidepressants, we oftentimes don't use them. They tend to have more side effects. There is also a huge risk of fatality with overdose, which is always a huge concern. So most of us tend to steer clear of those. Mood stabilizers like lithium, which were developed for bipolar disorder, but also can help with anxiety. And then there are a lot of anticonvulsants that also work as mood stabilizers, so those are listed as well. So these are some of the other medication options, but far and away that the SSRIs are most commonly used. So a couple of things I wanted to touch on. The first thing is stimulants like methylphenidate and Adderall are very frequently used for the treatment of ADHD, and for some people they really do help. Unfortunately, for a lot of people, it can actually make your anxiety symptoms worse. So that is something that's really important, especially if you have a child that may not be as verbal or as able to express themselves. It's really important to think about that fact, that maybe if you're treating and things are getting worse, it could be that anxiety is increasing. The other one, and I get this asked this question very frequently, can I just have a medication to calm them down just in those moments when I needed something fast? Benzodiazepines are what has been traditionally used for kind of those anxiety attacks or short acting. They really should be avoided, especially in children and adolescents. The problem with them is there is a high likelihood of tolerance, so over time you need increasing doses, which can be associated with overdose, which can be extremely dangerous. They also tend to develop dependence, so over time you need it, and when you stop them, there can be really significant withdrawal symptoms. They don't have great side effect profiles, especially in kids, and most of the time we recommend that those are really reserved for hospitalizations. So I know a lot of people are like, oh, if we could just get through this blood draw or this dentist appointment, but there are definitely huge risks with using those medications, so we don't recommend them. So we wanted to end up with just some resources. So these are some of the resources that we frequently use in our clinic and provide to families. So I'm going to leave that up there, and then I'm going to open it up for questions because I know we are a little bit behind and just have a few minutes. So does anyone have any specific questions? And we will also both be on the panel at the end. So if you guys think of questions about anxiety or anxiety topics, we'll also be back at the end so you can put those on those questions as well. So.
Is there a way to access your presentation?
Yes. So after all the presentations that are featured today with Day with the Experts will be on the Waste and Center's YouTube channel, and they'll also be archived on the Day with the Experts webpage. We'll have the video links to the talks today as well as PDFs of all the PowerPoints. Any other questions? Oh, back here.
Hi, I read Attitude magazine. I have 2 boys with autism as well as these commingling symptoms. Anxiety and ADHD. I have read that there are some video games that are by prescription only that may show some improved symptoms of, with anxiety. But I was wondering if you've heard of them, and I know some of them are don't have a lot of data yet. They're still collecting data. Could you address that?
Yeah, if you have some thoughts, you can too. Yeah, so as far as them being prescription only, I don't know of anything as far as video games or apps or anything that would require a prescription from a physician. Like you said, there is not great research in that. I have worked with an ADHD researcher who does specifically focus on like the video games for treating. And I think, although there is a lot of possibilities in the future, I don't think we're quite there at this point. I don't see that research right now to support that it really works well. I always tell people, if you have the ability to use those things or try those things out, I don't think it's a bad idea, but I always recommend kind of thinking about resources and your time, and are there ways that could be better kind of used to spend that. But I think I think there's a lot of focus on that right now, so my hope is that in the future we'll be able to utilize some of those strategies because of the really significant difficulty of getting kids in for therapy and help. It's a great question.
We have a question back here.
Mm-hmm.
I was wondering, what do you think about physical activity and exercise is helping with anxiety?
Yeah, I mean, I think that can always be a really helpful thing for different kinds of anxiety or mood concerns. Sometimes it might be thinking creatively about what that looks like for an individual person and what they'll really enjoy, but absolutely it can be really beneficial.
Yeah, I would definitely second that. Also, just, for kids and adults, we do know that that's oftentimes what a lot of the therapists recommend is to get regular exercise, especially being outdoors if possible. And that also is helpful for not only anxiety and depression symptoms, but ADHD. A lot of kids do much better if they have ADHD when they have exercise and kind of a regular way to move and kind of burn off some of that energy.
The question over here.
Just a quick follow-up to this one back here. Are there any, are there any video games or computer programs or anything that are associated or correlated with higher or lower degrees of anxiety? Do this, play this, it raises or lowers anxiety?
I am not aware of that, so I don't know about that. I'm not aware of it. I don't know if any.
Are there any coping mechanisms that might be specific to when kids on the spectrum don't have access to the things that they're repetitive or compulsive behaviors, and they express a lot of anxiety over that?
So when they don't have access to specific things, I think that's a little tough to answer because it might be so highly individualized, but certainly there are a number of different kinds of coping strategies we think about, and you know, some of those behavioral and physical and cognitive ones that I mentioned earlier. But there also can be some. It can be helpful to think about what is that person's interests, and can those be used in a really planful way to help impact the usefulness of some of those coping strategies. And so oftentimes some of those interests can be incorporated in sort of a adaptive way, but I'd be happy to talk more. I don't know if you have
Got a question right over here?
Oh, I'm sorry, please.
Go ahead. No, go ahead. I'm good.
How does anxiety show up in like nonverbal autism?
Yeah, so what we tend to see more is a lot more of the refusal behaviors. So lots of refusal behaviors, also like increases in aggression, increases in self-injurious behavior. So that's a lot of times what I see, and sleep issues as well. Yeah, so that's what I see most commonly.
So I think we are going to end for questions for now. As you noted, we're just a little bit off of our time schedule for today. I want to give all of our speakers the time that they have budgeted to do their presentation. So we're just going to cut into our clinician panel. That'll just be shortened just slightly in order to accommodate all the presentations. So let's give Danielle and Martha a round of applause. And thanks. And then we'd like to welcome Dr. James Lee.
Okay. Hi, everyone. Thank you all for being here. It's an honor to be a presenter on this Day of the Experts. I realize that we have a lot of people streaming in, so welcome to you. Hope everyone there is warm. So I just want to say a little bit about myself. My name is James Lee. I'm an assistant professor in the Department of Psychology here at UW-Madison. I've been here since 2015, and I've also been a Weissman Center investigator since that time as well. Most of my academic career has been focused on the study of the causes and consequences, and to some extent the treatments, for childhood attention deficit hyperactivity disorder, or ADHD. And one of the things I've had the great privilege of having here as an investigator at the Weissman Center is a tremendous opportunity to be able to communicate and meet with many of my colleagues who are experts in autism, or ASD. And as I've been here and as I've been doing my studies on children with ADHD, I have really come to realize how much overlap there is in the context of children with autism who also have signs and symptoms, and in some cases diagnoses that are also ADHD as well. So I'm going to talk a little bit more about where my research has been going, very recently in fact, as well as to focus a little bit more about what ADHD is in the first place. I've already heard some questions about that, and our previous speakers had mentioned it as well. I'm going to talk a little bit about what we currently know about its overlap with ASD, and then I'm going to end with some work that we're currently doing that's still in its preliminary stages, but I think is really exciting, and hopefully will shed some more light on what exactly is going on when we say that these two disorders overlap. So let's start with what is ADHD. And presumably some of you may already know this, but for those of you who don't, here's a little snapshot of how the DSM, or the Diagnostic and Statistical Manual, defines it. So there are two major clusters that define ADHD. The first major cluster of symptoms and problems are what are called the inattention problems or cluster. This has to do with the general inability to sustain attention or to stick to tasks or play activities for long periods of time, or to remember or follow through on instructions and rules, and to resist distractions. You heard this in the anxiety discussion, that actually, if you think about all of these different symptoms, all of us probably will say that there are times when we can't sustain our attention or stick to tasks or activities or remember to follow through on instructions. So there's really nothing out of the ordinary if you yourself see yourself doing some of these things. But what is out of the ordinary is that when these types of behaviors become so impairing that it makes it difficult for you to do your job or to go to school or to learn, that's what we're referring to when we're talking about inattention symptoms from a diagnostic perspective. The other major cluster is the hyperactivity or impulsive cluster. This has to do with a set of symptoms that have to do with under control of motor behavior, a poor ability to inhibit one's behavior, and an inability to delay a response to something that's typically very rewarding. So these are typically children who might have a harder time saying no or refraining from getting that toy that they really want or wanting to play video games. They have a really hard time not being able to do that. So hyperactivity in particular refers to the under control of motor behavior. So this will typically manifest as having a hard time sitting still or fidgeting a lot while they're sitting still, even if they are sitting, squirming around, running around aimlessly. And another one that is actually used in the DSM is called being driven by a motor, as if they're like cars and they just can't stop. The other aspect of hyperactivity and impulsivity is, of course, the impulsivity, which relates to inability to inhibit immediate responses to really good stimuli that they're looking forward to. This might look like blurting out when they're, or interrupting others, or having a hard time waiting for their turn. So they typically might have a hard time waiting for their turn. There are multiple subtypes for ADHD. There are three. The first is the combined subtype or combined presentation. This has to do if when the child meets the diagnostic criteria for both the inattention cluster and the hyperactivity impulsivity cluster. So we would call a child who's been diagnosed with combined type, that child would have symptoms of both of those clusters. Then, of course, you have the predominantly inattentive subtype, and that, of course, would be a child who might meet all of the diagnostic criteria necessary for the inattentive cluster, but not the hyperactivity impulsivity cluster. And then, of course, you have the predominantly hyperactive impulsive presentation or subtype, and that's when they meet the diagnostic criteria for just the hyperactivity impulsivity, but not inattention. There are differing degrees of severity, as there are for many of the disorders of the DSM. I would argue that ADHD is also a spectrum. It's not currently called one right now, but as you can see, there is a slow movement towards that for not just ADHD, but for a lot of disorders as well. Okay, so I like to show this quote, especially when I teach about ADHD in class and speak to organizations about just exactly where this field has come from and where it is currently. So back in the 1960s, when we began our studies, no one believed such children existed, such children being children with attention deficit hyperactivity disorder. Now people find them under every rock, and this was somebody who was a psychiatrist who was among the first people to study ADHD. There is an increase in prevalence in ADHD over time, not unlike what we've seen in ASD. This may or may not be surprising to you. So since 1997, where we've done national surveys to track its prevalence, we're seeing that there's a general and steady increase in the prevalence rate of ADHD. And these are all different national surveys that have been conducted on children. One of the more startling things about this is that its average prevalence is really high. So we're talking about between 9 and 10% of children currently are being diagnosed with ADHD today. So that's substantially higher than most other childhood psychological disorders, including, of course, autism spectrum disorder. That means that, in a class of 30 children, as many as 3 of them might have ADHD. And this increase in prevalence actually has an interesting pattern to it. that we're also trying to understand from a research perspective. So this shows you in 2003 when the CDC was tracking prevalence rates for ADHD, they were doing them by state. And what you'll notice here is that tends to be a higher prevalence in southern states and some in the mid-Atlantic states for ADHD. So the darker color, the darker shade of green here represents 13% prevalence in that state and above. So as you can see, no state is around 13%, but they were between 9 and 10% in the southern region as well as the mid-Atlantic. And then if you look at the West Coast and even some of the Midwest, a bit lower. Here's what it looks like in 2007, so this is just 4 years later, and you can see a huge increase in prevalence in some of the Midwestern states, and of course some of the southern states as well. And the western states still remain fairly low prevalence relative to some of the southern and mid-eastern states. And then here's what we see in 2011. So this is 4 years after this. The prevalence now is firmly above 13% in many states, including, of course, Midwest and the southern states and the mid-Atlantic. And then the West Coast remains about 7 to 9%. Now, there aren't updated figures since 2011 by state level, but as you can see, when I said that the national prevalence was 9 to 10%, that's not representative of the fact that some states have much higher prevalence rates than others. Now, I wasn't intending to go over why there are differences in prevalence rates across states, but I will say that there have been many potential explanations for this, some of which have to do with educational laws, and others have to do with things like being more aware of ADHD, and certain communities in certain states might have done a lot more to try to make it more aware among teachers in particular. There have been lots of studies that have been trying to understand this phenomenon that's been going on. It doesn't quite make sense why a neurodevelopmental disorder should look like this, and I'd be curious to hear any of your thoughts on this. But needless to say, it's a strange phenomenon, but one that does suggest that it is growing in prevalence, but it doesn't seem to be growing in prevalence consistently, depending on what state you're in. Okay, I want to talk a little bit also about treatments for ADHD. You've heard a little bit about that in the context of anxiety, and I want to continue that in the context this time for ADHD. We actually do have a gold standard treatment for ADHD as a disorder. And that gold standard was established by a randomized controlled trial that was led by and conducted and funded through the National Institute of Mental Health, called the MTA study. This was done in the 90s and published in the late 90s. It was a study that involved 3 different types of treatments. One was medications only, and they were looking at the effects of a stimulant medication. In this case, it was methylphenidate. The other treatment group was those who did a behavioral treatment. So specifically, these were kids who not only got individualized behavioral treatments on learning how to better stimulate themselves in ways that don't disrupt everyone around them, but the families also got a parent management training session, 10 of them in fact, where they learned how to better manage the behaviors of their children at home. And then the third treatment group was a combined treatment group where they got both the medication and the behavioral/parent management training. There was actually a 4th category. This is treatment as usual. Typically, a lot of randomized controlled trials have this category where a set of families and children with ADHD were told to just get whatever treatment you wanted in the community, whatever was available. This was the primary finding from MTA that has led to the gold standard treatment, which is to show you simply that the combined treatment group responded best and had the best outcomes in terms of what they said normalization, which is when you have symptoms that go all the way under the under the threshold of diagnosis. So these were children who were previously diagnosed with ADHD. They did the treatment, they no longer had a diagnosis of ADHD. So 68% of the children who were in the combined treatment group responded in this way. They normalized. 56% who just received medications only, this is the methylphenidate group, responded this way, and 34% responded in a normalized way to just behavioral treatment only. I should mention that all of the children in this study were children who had combined type ADHD, which would be considered the most severe type of ADHD. So in the case of a child who has the most severe manifestation of ADHD, they respond best to a combined treatment. And this is what is the gold standard treatment today. This is what pediatricians would recommend, is that you don't just get medications when you treat your child with ADHD. You should, as much as possible, to the extent that it's available, receive both, especially if your child has a combined type presentation. This isn't necessarily true if the child might have, say, a predominantly inattentive subtype or hyperactive impulsive subtype. So a little bit about parent management training, which is a part of the MTA study. This is a behavioral intervention that focuses on teaching effective parenting practices and strategies for coping with a child with ADHD. So it really does focus mostly on parents rather than the child themselves. It actually includes a lot of components from applied behavioral analysis, and its goal is to teach skills to parents, but also children, but mostly to parents, that help increase positive adaptive behaviors, typically in the home setting, and then to decrease maladaptive behaviors. This is Russ Barkley. He wrote a book called Taking Charge of ADHD that is widely used in ADHD treatments that specifically walks parents and clinicians through how to do parent management training in a very time-limited sort of way. All right, so medications. I know that some folks might be interested in learning a little bit more about the types of medications that are used. And I'm not going to necessarily go into depth on this, but I did want to share a little bit about what are typically being used. And we also have an expert here, a pediatrician who works with children and families with ADHD who can probably answer some of those questions better than I can. Stimulants are among the most widely prescribed types of medications for ADHD today, and has been for quite a while. Stimulants, there are different types of stimulants. Many of you may have heard of Adderall, for instance. That's what's called an amphetamine. But there's also Ritalin, which is an older type of drug, but it's still used today, and that's what's called the methylphenidate, as well as drugs like Vyvanse that are currently on the market and increasing in popularity. These are all categorized as stimulants because they all increase the amount of dopamine that's available in the brain. And not only does it increase dopamine, which is one of the neurotransmitters that's quite involved in the way that we process rewards, but it also increases NE or norepinephrine in the prefrontal cortex. And this has a lot to do with our arousal, our awakeness, our sleep-wake behaviors, and it also impacts our fight-or-flight response, among other things. So both of these neurotransmitters are impacted when children are taking stimulant medications. We also have another class of drugs that are widely used today to treat children and also non-children with ADHD, and those are called non-stimulants. And that really isn't all that different in terms of its mechanism from the stimulants, other than the fact that it doesn't primarily focus on increasing dopamine. So Strattera is a good example of a non-stimulant. Most of these drugs are typically released, if not all, actually all of them are released in the central nervous system, and they usually are released over time and fairly quickly once somebody takes them. In some cases, these drugs can last for almost 24 hours or longer. The longer acting ones are typically denoted as XR, or extended release. And typically, if you want the therapeutic effects of a stimulant, they need to be taken every day. Of course, as I said earlier, some drug companies are developing new mechanisms of delivery that one can take it once every other day instead of every day, because sometimes parents or individuals with ADHD might forget, which is actually a core symptom of ADHD itself. Okay, so what does the landscape of medications and behavioral treatments and whether or not people actually use the gold standard treatment for ADHD look like? So the CDC actually publishes a nice figure by state. As you saw on the figure that I showed you, there are different prevalence rates by state, but there are also different patterns in which people practice the treatment of ADHD by state. So I've highlighted Wisconsin here, and you can sort of see here in the top part of the graph that among children with ADHD, so these are individuals who've already been diagnosed with the disorder by a pediatrician or a psychiatrist, 81% of children who have diagnosed ADHD in the state of Wisconsin are being medicated. So these are 81% of any child who walks into a clinic with ADHD is likely to be medicated. Relative to the rest of the US, including DC, that's about 74%. So we're somewhat in line with the average, but as you can see, a bit higher. We're more likely, a little bit more likely here to medicate our children. So that may or may not be a bad thing necessarily, but let's look at behavioral treatment. So this was somewhat older data, 2009, 2010, 38% of children with ADHD in Wisconsin received behavioral treatment for ADHD, and this is reporting in the last 12 months. Relative to the national average of 44%. So in the state of Wisconsin, we're a little less likely to have our children, or to recommend our children, or to have our children with ADHD also undergo some form of behavioral treatment. So what about both, that being the gold standard? Wisconsin is at 31%, where children with ADHD receive both medication plus behavioral treatment. And that's actually in line with the national average of 31%. I don't know how you all feel about that, but for me, as a researcher, this doesn't make me feel great, because we know from our research and evidence-based studies, RCTs, that the combined treatment is typically considered what everyone should be receiving, especially when you have a young child who's maybe 6 or 7. There are side effects of these medications that I unfortunately don't have a slide on, for which we actually don't quite know what will happen to a child's brain as they get older when they're taking these medications. And that's, I think, somewhat problematic. The impact of ADHD is quite profound, as you can imagine. So not only is it quite prevalent, among the most prevalent mental disorders of the DSM, in fact, but it also, as you can imagine, has a tremendous negative impact on academic functioning for that child. It's harder for them to sit still, and so it might make it also harder for them to learn. And it also has a very negative impact on social functioning. Typically, children with ADHD have a harder time making friends, and that has a negative lasting influence on the way that they develop in life later on. And of course, it has a negative economic impact as well. This was an estimate that was given by the CDC. In fact, almost $31.5 billion annual cost that ADHD has on our healthcare system through lost productivity and impact on other family members. So this is a highly prevalent and impactful disorder. Okay, I'm going to now transition to an area that's becoming increasingly interesting and also important to study, and that is the overlap between ADHD and autism spectrum disorder. So one question to ask before we even get into this is, can a person even have both of these disorders? Interestingly, for many, many years, decades in fact, the DSM actually said that you cannot have ADHD if you already have a diagnosis of ASD. And the opposite was true. And it wasn't until 2013, when the DSM-5 came out, that researchers finally raised their voice and said, this is preposterous. Not only can you have them, but there's a lot of value in having a dual diagnosis in this case of ADHD and ASD. Why is there value? It's because when there are symptoms of ADHD and they're very impairing on that individual, and maybe those symptoms are not necessarily what you would see in autism, right? They would require ADHD-specific interventions. And so the opposite is true the other way around as well. So there is a lot of value in studying this and treating the co-occurrence of ADHD and ASD. Now, in the DSM-5, they're all counted as part of the same clusters of disorders. They're all part of something that are called neurodevelopmental disorders. There's actually 6 of them in the DSM-5. You can see ADHD and ASD are like the first 2 that are shown, but learning disorders also fall under the category of neurodevelopmental disorders: communication, motor, and intellectual disability. So you've heard some examples of them in the introduction slides that Chung gave. All of these disorders are characterized by a similar origin. So many of them are early expressing problematic symptoms that you typically be able to see early in life. And they all have some sort of shared origin in the sense that they are led to, they're impacted by the impairment of the growth and development of the brain. So they impact brain development in some way. Maybe not all in the same ways, but they all impact brain development in some way. And those can then impact your emotion, the way that you regulate your emotion, how you learn, your self-control, and your memory. So there is a belief that having a disorder among this group of disorders, that you're very likely to share many of the same features as some of the other ones within them. So talking a little bit more about this overlap, what might this overlap look like in a clinic, say if your child does present with autism and might have some ADHD? So there are a few red flags to pay attention to, especially if you're a clinician or if you're a parent who might be concerned. The first red flag that I'll talk a little bit about, and this was identified in a recent paper that was written by psychiatrists in Europe who have been among the leaders actually in studying this overlap, is one of the symptoms of ADHD, which is often fails to give close attention to details or makes careless errors in schoolwork, at work, or during other activities. This is an actual symptom in the DSM-5 of ADHD in the inattention cluster. Typically in children with ASD, this isn't the case. Children with ASD are perhaps more likely to give close attention to details and not to make careless errors because they're so focused on a specific object or detail during an activity. But when a child with ASD does present with these types of this particular symptom, it might be indicative of ADHD. Here's another one. Often has difficulty sustaining attention in tasks or activities, or unable to play or engage in leisure activities quietly. This is more representative of ADHD than, say, ASD is, for the same reason that I mentioned in the first case. Another one that might be a red flag symptom of ADHD co-occurring with a child who already has ASD is often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort. As many of you may know, children with ASD, particularly ASD in fact, they crave structure and repetition and things that are more rote and repetitive because they can expect something. In this case, often disliking engaging in activities that are that way would be more representative perhaps of an ADHD diagnosis. Often loses things necessary for tasks or play activities. You wouldn't typically find that in a child with ASD, but in this case, if they have those types of symptoms, that might be representative of ADHD. And then the last one that they pointed out as being a red flag was often being forgetful in daily activities. Again, you may not necessarily see that very often in a child with only ASD, but if you do see that, that might be reflective of a potential comorbid diagnosis of ADHD. This is the opposite. So this is if you're trying to identify ASD in a child with ADHD. So I'm not going to go over this slide, but there are some that have been noted as well there. How common is this overlap? So this is according to a study that was done about 8 years ago. So it's not exactly the newest study that I could find, but this is the best study that I can find by Scott Collins and his group at Duke. As many as 50% of individuals with autism spectrum disorder present with signs of ADHD. That is not to say that 50% of people with autism spectrum disorder have ADHD, but rather that as many as 50% present with signs or symptoms of ADHD, suggesting that there could be impairment related to ADHD that may not be treated. And then the opposite is also very true. Nearly 2/3 of individuals with ADHD, which is what I've been focusing on most of my career, present with features or signs of ASD. So this overlap is not trivial. It happens quite frequently, and it may even be expected given how common it is. Individuals with ASD are 22 times higher have a 22 times higher risk of having ADHD compared to those who do not have ADHD. So again, this is a risk that is not trivial and I think deserves to be studied, especially now that we can officially diagnose the two of them together. What sort of treatments do we have for the co-occurrence? So not about ADHD and not about ASD, which I'm sure many of you already know about, but what about if you have a child who presents with both? So I wish I had satisfying results and great things to tell you about our great treatments for this, and but we're working on it. We don't quite know what to do yet. But here's what is the current practice. The current practice is to medicate them. So compared to youths with ADHD or ASD alone, and this is from a study that was done in 2011, so not exactly the newest, youths with both of these disorders are the most likely group among those who don't, relative to those who don't have both, to be prescribed some kind of psychotropic medication. So when I say psychotropic medication, I mean any medication that's designed to target the brain in some way. So it could be an anxiolytic, it could be a benzodiazepine, it could be a stimulant. It's any drug, really. They're the most likely group to be medicated, and that, in fact, is the current practice. May not be the right practice, but is currently what has been done. There's no current compelling evidence, i.e. through randomized controlled trials, that indicate that children with ASD and ADHD even respond well to these treatments. So just because this is what's being done doesn't mean that this is the right way to do it, because we don't have any solid evidence from randomized controlled trials like the MTA study that has told us that this is the right way to do it. We're still searching for that. And in fact, there is some evidence to suggest that children with both of these disorders who are medicated don't even respond well to it at all. In fact, may actually be contraindicated. You heard from our previous speakers how you might actually make anxiety worse when you give a child you give stimulants to a child who might have ASD or might have anxiety. So that's one of the issues with our current practice right now, is that not only do we not know enough about what type of medication to prescribe a child with a co-occurring disorder, whether it's ADHD or anxiety, but we might even be making things worse because we don't know enough about it. So this is why I've become quite interested in this and have been able to rope in other people to become interested in this with me as well. So I'm going to talk a little bit about the research that we're currently doing, and I won't spend too much time on this because while it's very exciting, it's also just getting off the ground. And so we have a little bit to share, and I'll tease that to you today. I have predominantly studied my things of interest, ADHD and childhood disorders, from a genetic perspective. Why from a genetic perspective? Because many psychological disorders have a strong genetic basis. We've learned this over several decades of research looking at twins, where we've learned that, for instance, schizophrenia has a heritability of 81 or 81%, bipolar 75%, suggesting that the vast majority of the potential causes of schizophrenia and bipolar, at least 3/4 of it anyways, can be attributed to genetic factors. You can see here, this is for MDD or major depressive disorders, a little less. So it's not trivial, but it's 37%. And then here are the other two that we're focusing on today. Autism is around 80%. The most recent estimate is around 83%, so it hasn't really changed all that much, even with more data coming in. And ADHD here is 75 to 80% actually. So we're talking about two of the more heritable disorders according to estimates from decades and tens of thousands of twins that we've studied, some of which have been studied here, as a matter of fact. This is a complicated looking figure that I just want to show you and point out one thing. What we currently do in the field of genetics is we don't just focus on twins any longer. We can actually look at your DNA. Anyone here done a 23andMe? Anyone know about 23andMe? Right? So now you can actually pay a company and give them your spit and they can read out your DNA sequence. Well, we've been doing that well before 23andMe. And there have been studies now on all sorts of heritable disorders and other traits like height, trying to look for, well, what specific genes are associated with these disorders. If we know autism is about 80% heritable, then what are the genes that are actually contributing to that 80%? That's obviously a really important next step now that we have the technology to do it, because once we identify what those genes are, we may actually be able to produce some therapeutics around them and even do something about that. So what this figure shows you is a sample of over 50,000 people with and without autism, one of the largest studies ever. It's actually a combination of many different clinics collaborating with one another who have all produced genetic information on their samples, and they've combined their efforts in search of genes for autism. Essentially what this study shows you, this is what's called the genome-wide association study, shows you for autism, is that anything above this red line is what's considered a genome-wide significant hit. It was a gene that is so significantly associated with autism that it survives the burden of multiple testing. There are a lot of signals below this red line that sort of show some potential signal, but not strong enough, basically. These are the ones up here that are really strong. So you may not be able to see it because it's kind of faint, but there's actually a lot of signals that are associated with autism. And we've done this for ADHD too, and we're also seeing very similar things. Different signals across the genome, but signals nonetheless. What we're now able to do with this type of information is quite powerful. What we can do is actually genotype every person that walks into our research study, and we can then sort of aggregate and focus and hone in on all of those genes that have showed up in that big study that is associated with autism. We can measure which version of the gene that you have across all those associated variants up here. We can measure that in you, and then we can produce what is called a polygenic risk score for autism, meaning how many of those risk variants do you carry that has been already identified for autism. And when we do that, we can do that for everyone, whether you have autism or not, and we can determine how much more of the genetic burden for autism do you have relative to the typical person. And so this is an example where, say, if we genotype one person, this person has more than 89% risk, carries enough risk that they're at an 89% probability of potentially having autism. So this is a very powerful tool that we now have at our disposal as we've learned more and more about the genetics of autism, that we can combine things that we learn from GWAS to help us make potential predictions about where you might stand on the liability spectrum of risk for autism. And this goes back to the idea that autism is a spectrum. Your genetic risk is also a spectrum. And many of us actually carry genetic risk, and it just may not express. So I've done this type of work in the context of ADHD. This is just a recent study that I published not too long ago, looking at a very big data set called AdHealth that's got 15,000 adolescents in it. These are adolescents who are just from the community in the US. And what I'm showing here is what happens if you were to produce this polygenic risk score for ADHD in a normal population of adolescents in the US. This is what you find. This is a normal distribution. It's a spectrum of genetic risk that corresponds to your actual risk for ADHD. So if you're over here, all the way on the right, this means that you're 2 standard deviations above the mean in terms of your genetic risk for ADHD. You're carrying so much of the genetic risk for ADHD that you're higher than, say, 99% of the population in terms of your genetic risk. And when you're over here in the genetic risk spectrum, you're about 2 times as likely to have ADHD, and this is something that was measured in AdHealth. So this is information that's telling us that just simply having your genetic, your DNA, your genetic information can actually help us potentially diagnose ADHD. Not by itself, we're not that good yet because there's still a long way to go before we've identified all of the genes for ADHD or autism, but we're starting to get there, and it's starting to give us some clues as to just how much does that translate into real life risk for this disorder. Okay, so this got me wondering, given the overlap between autism and ADHD, that what if some of the genes for ADHD might actually be the same genes that we're looking at for ASD2? Here's another somewhat complicated figure, but one that highlights something that I just really want to point out. So this is a set of correlations. So on the bottom is R, which is this is a Pearson's correlation. And over here, you can see different types of traits. And what they've done in this particular study, this is a study that was done in 2019 in Nature Genetics, was that they looked at the genome-wide association scan for autism. So the graph, the figure that I showed you with all the little dots on it, and then the red line with all the dots above showing the significant hits for it. How correlated are those genes to things like IQ, educational attainment, self-reported tiredness, neuroticism, schizophrenia, major depression, ADHD, chronotype? What you're seeing is that most of the genes for autism are also associated with the traits that are typically associated with autism, like your IQ, educational attainment, self-reported tiredness, and, not surprisingly, ADHD as well. In fact, ADHD was one of the most correlated traits with the genetics of autism. This is really confirming our suspicion that when we're talking about overlap, it may not be just any kind of overlap. We may actually be seeing the same signals, the same genes are what's contributing to the overlap between ASD and ADHD and potentially other traits as well. Another thing that we've learned from genetic studies and also from some neurobiological studies is that many of these genes, both for ASD and ADHD, are actually enriched or overexpressed in the same brain regions. So it's the same signals are showing up in the brain as well. It's not just the genes, but the genes contributing to protein expression in the brain, and they're expressed in the same parts of the brain, which is quite indicative or suggestive that what we're looking at here when we're talking about overlap are some of the same signals. So what we're currently doing at the Weissman Center in collaboration with another lab here at the Weissman Center, the Motor Development Lab, is we're combining some of our efforts and our expertise to help us better understand really what the causes of this overlap are. So my lab, the Social and Behavioral Development Lab, uses genetic information from our participants where we have them come in, we recruit them into our lab, and we study their DNA, and we also study the home environment and the school. So we're trying to capture not just the biology, but the environment as well. And we're combining that with really powerful and high resolution images of the brain to help us see if we can do a better job of distinguishing those who have both ASD and ADHD from those who might have just predominantly ADHD or just ASD alone. It's still, of course, very likely that there are some individuals who only have ASD and not the other, and vice versa. But the challenge right now that we've encountered is that we're not really doing a great job of diagnosing it. It's hard to find that. It's hard to do it reliably. And of course, we don't know how to treat it yet. So before you treat something, you ought to know how to diagnose it and identify it first. That's just my opinion. So that's kind of what we're focusing on here at the Weissman Center and collaborating with our wonderful experts here. And that's one of the great things about being at the Weissman Center as a faculty investigator is having such great collaborators like Brittany Travers, who runs the Motor and Brain Development Lab, so that we can better understand the causes, the origins that can ultimately lead to precision diagnostics, which is what we're interested in. So this is our set of guiding questions for our research project. Can genetic information be used to diagnose ASD, ADHD, and their co-occurrence early in life? That's one of our key questions that we're trying to answer by collecting genetic data from them. But with the incorporation of imaging data of the brain, can this genetic information also be traced to brain regions so that we know which areas of the brain to target in the development of new therapeutics? This will help us link the genetic signals that we find to the actual brain signals that we've also started to find. They have to, we want to see whether or not those are related so that it can lead us to some new areas to pursue for developing new drugs potentially down the line. We have some really preliminary results, but I'm really excited about them. This is actually data that's not from the study that we're starting here at the Weissman Center, which is just about to get underway. This is actually data from a large data set of individuals with diagnosed autism. This is, I believe, 50,000 people with autism. It's called the SPARK data set, and it comes from the Simons Foundation. And what we've been able to do with that data is we've been able to use our polygenic scoring models for autism, or ASD, to predict autism in the SPARK data set. What's interesting about this is that a lot of the folks in the SPARK data set also have ADHD. And one issue or one limitation of polygenic scoring methods is that they're not very precise, they're not very reliable. Remember that I told you that many of the genes for ASD might also be the same as the genes for ADHD, right? So if you're trying to see whether or not somebody has ASD just by looking at their genetics, you don't want that to pick up signals for other disorders too. You don't want that to be picking up things for depression or schizophrenia or ADHD. You want the signals just to be focused on ASD, because eventually what our goal is to use genetic information to help us diagnose precisely. So this is essentially what we've been able to do using some cool bioinformatic methods that our other collaborators have helped us with. This shows the prediction of using genetics of autism to predict ADHD. So it doesn't really predict ADHD all that well in this sample. And it does even better job when you're refining the genetic signal just to be focused on ASD. And the same thing is true when we're doing it the other way around. Genes for ADHD only predict ADHD. We've started to come up with ways to be more precise using genetics to predict the thing that we want to predict. Yeah, so that's the idea here, is that genetic information may be useful for early diagnosis. And you've heard already the Weissman Center's mission. And of course, one of the key missions for us here altogether is that not only do we want to help families, but we want to do it early, because early interventions have been shown to lead to better outcomes in most cases. This is the type of work that's been happening all over the place and has been going on for a long time in the autism world. You know, this is an example of a study that was done in 2013 where they've used eye tracking devices to study infants, where they've looked at infants' eye gaze to see how much are they focusing on the face versus something other than the face. And they're using eye tracking methods to try to early diagnose individuals or infants who might go on to have autism. Imagine if we can do this at the moment that they are born, where we can identify someone's risk for autism using only their genetics. So there's a lot of positive potential. There might be some negative consequences to that type of work as well. But we're very excited about what genetic information and neuroimaging information can potentially do to help us better understand the causes of these disorders, but also importantly, the causes of what causes the overlap between these two disorders. And with that, I'm going to end and field any questions that you have about this presentation. Thank you.
I know there may be questions, but in the just trying to be mindful of the time frame. I think we're going to skip questions for this presentation, and James, I don't know if you're able to stay like for the clinician panel. Maybe he can field some questions related to this topic then. We're just going to take a 5-minute break as we transition. So the bathrooms are located right behind us. In 5 minutes, we're going to resume with Leanne Smith-DeWalt's presentation on working together. By Leanne Smith DeWalt. Hello, hello. So be careful as you're climbing with bags and boots and coats, and we're going to jump into our next presentation, which is some work we've been doing here at the Weisman Center about related to supporting adults on the spectrum. So just to jump right in, why should we provide support? I'm talking about a developmental period called emerging adulthood. I'm a developmental psychologist by training, and what we've learned is that you don't turn 18 and suddenly are an adult, that it's a period of growth and development that actually is really important. And so why should we provide support to individuals during this time and to their families? As some of you who may have gone through this process already may know, is that there's a really significant loss of services when people exit school and move into what happens next. Not surprisingly, this period of emerging into adult life can be very stressful for individuals on the autism spectrum, and in turn can be very stressful for the people who love them and spend life with them. Unfortunately, there hasn't been a lot of research about adults and aging and ASD, and even less on what are the best ways to provide support. So I said, I think that we have a pretty good sense that it can be stressful and that there can be challenges, but we don't really know how to help. And so what I'm going to talk today is some of the work we've been doing to try to answer that question. So we decided to develop a program called Working Together, based on sort of this need of how do we help individuals on the spectrum really land into adulthood in a way that they feel good about and those who love them feel good about. So we really started by trying to understand from families who have been through this process of transition into adult life, what has worked for them. So we have a 15-year longitudinal study that many in the room actually have participated in here at the Weisman Center, where we were able to find clues into what worked best for the prior generation of families. And we also conducted lots of focus groups with individuals on the spectrum, with their family members, their service providers. We took all of that information and did some small piloting of a curriculum, and then continued to refine, worked with a stakeholder advisory board. Really, that if you're trying to develop an intervention or a treatment or services, you don't just make it up and then decide that it works. It really should be an iterative process of connecting to see not only does it change the outcomes you're interested in, but does the person with autism want to do the thing you're wanting to provide them, right? And so if it isn't engaging or feeling beneficial to someone on the spectrum, we probably shouldn't persist in trying to push it on them or spread it around the country. So the program, after all of this long period of development and back and forth to try to refine the curriculum, we landed with a program that had 3 main goals. So to provide education on topics related to ASD during adulthood, provide opportunities for social networking and support, both for people with autism and their family members, and then in all of this, really emphasizing positivity and problem solving. So some of what we've heard about already today around the evidence base for cognitive behavioral therapies and strategies is that we know that we can empower people to figure problems out for themselves, and how can we do that in a way that's supportive. And for this particular study, we were interested in, for the adults on the spectrum, were they engaging in activities that they found meaningful, and what was their behavioral functioning. And I'm going to focus on the behavioral functioning today, mainly because we just heard about anxiety and ADHD, and so I thought you might be interested in some of our findings related to that. So how does this program that we developed work? We have 2 sessions that would be just with an individual family, so the young adult on the spectrum and their family members who might want to participate. And that's a time to really listen and understand sort of the history for the person on the spectrum and their goals and hopes for the future. We find that a lot of times there haven't been opportunities to really listen, and so this is a good time for people to really share their journey. And individuals and families actually have a lot of expertise in themselves and their lives and what has worked up until the point that they're 25, right? And so as practitioners and professionals, we really need to listen to that. And so that's why when people ask like, oh, could we cut that out? No, because you need to take time to get to know people individually. Then there are 8 weekly multi-family group sessions, so multiple families come together in the same room. And we tend to have the young adults on the spectrum in one room and then their family members in a different room. For this particular study, we also wanted to follow families not just for the 8 weeks, but over a period of several months in a less intensive way, knowing that what we're doing, emerging into adulthood, doesn't happen overnight. And so in some of our prior work, we found that providing that ongoing support probably would be helpful. And then ongoing resources and referrals to things that might not be targeted specifically by this 8-week curriculum, but we know families might be looking for and needing. So here are the session topics, again, that were established in sort of this iterative process where sort of families come together. The second week, we really focus on goal setting and problem solving. It's not always the easiest thing to set a goal and know how to do that. And for many people on the spectrum, life hasn't always worked out. And so it can actually be really hard to think about setting a goal if the world hasn't been fair and you haven't achieved some goals in the past. And so to be brave and to try to do that again can be hard. And so we talk about goal setting, and then when maybe you don't immediately have success in your goal, how can you look at what's happened and try to solve the problem and take the step again? And so we really hit that right at the beginning. And then we get into coping strategies, planning for independence. So what are the things you want to do more by yourself as an adult, and what would that look like? Employment, because that's often an activity that is meaningful for people, including people on the spectrum. Community and relationships, personal safety. I think that we all need to think about ways that engaging in the world without like your parents there all the time, that how can we do that in a way that feels safe? And then health and well-being. I mentioned before, we have a whole line of work looking at stress and its impact on health. And so if we know that individuals on the spectrum have a high amount of stress, their families do, we need to really be thinking carefully about how we are maintaining our health and well-being and be really intentional about that. So those are our topics. And I said, again, we work with the young adults for them to think about their goals. And I thought you might be interested to see the types of goals. So we've actually categorized across all the adults that have participated with us what their goals are. And 70% of the young adults were really interested in a goal that was job related. I think what's really important and a new area for me of research actually is a lot of them wanted a job that was a steady job, that felt like a career job, that wasn't going to be like short term and come and go. We see a lot of employment instability for adults on the spectrum, and I think that, like many of us, they really don't want something that's only going to be short term or unsteady, or something that doesn't feel meaningful to them. And so I think that's really important when we think about employment. It's not just, oh, they have a job today and check that off the list and now we're done. It's how can we think about careers for individuals on the spectrum, because that is important to them. A little less than half had goals that were social, so either wanting to make friends because they didn't feel that they had any, or spending more time with the friends they had. A little under half had goals we put in the category of independence. So maybe they didn't want to live with their parents anymore. They wanted to get a driver's license. That's something that they felt they might be able to try, and they wanted to try it out. Interestingly, and this was not what we sort of were saying the intervention was about, a quarter of them had goals related to health, so very personal goals about knowing they needed to lose weight, wanting to exercise more, feeling like there were a lot of barriers for them to be in good health, and trying to take some action themselves around their eating or their exercise. And I think that that was something I wasn't necessarily expecting, and now I want to be more mindful of partnering with people on the spectrum related to health. And almost 30% had something I would consider like a personal goal or something that's really kind of hard to categorize. So they wanted to start a blog, or maybe they are really into, like here are these examples, like they wanted a cat, right? So that's really kind of personal, and I think that's important that sometimes, particularly in the educational setting when we're doing transition planning, it's all about get them a job and they need to have the daily living skills so they can do their own laundry. But when we're thinking about adult life and what's meaningful for someone, well, maybe we should think about, could we get them a cat? And how could we do that in a way that's going to make sense? So we did a randomized waitlist control trial. So this means that the control group were people that were waiting eventually to get the program, but they didn't initially. And we had families in Wisconsin as well as Minnesota. And for this particular study, it was an average to high IQ sample, and I can talk a little bit about our future work for other subgroups of the autism spectrum, but that was the group. And 80% had at least one mental health diagnosis. So again, we were talking about anxiety, ADHD. This was a group that did have pretty significant co-occurring other challenges. So what I'm going to talk to you now is just a little bit of the data that we collected at baseline, 3 months and 6 months. Again, the period of time of the intervention was 6 months, but the first 3 months were more intensive and the last 3 months were less intensive. Importantly, at the start of the study, there weren't any differences between the groups on anything. So randomization worked, which is always really good, that we can feel confident that the changes that we see weren't because they were different in the beginning. So just quickly, and it doesn't look very impressive when you see it on the slide this way, but I think it's really meaningful. So these are behavioral challenges. So these would be challenges such as what we were talking about already this morning. So withdrawing and having difficulty being around people, difficulty sort of doing inappropriate social outbursts, so like saying, like laughing at the wrong times, different types of both internalizing and externalizing behaviors. The blue line are the people in the intervention, the red line are the people in the control group. Basically, over time, the number of these behavioral challenges the control group had didn't change over the 6 month period of time, but those in the intervention, they had fewer behavioral challenges over time. So they actually dropped a behavior problem, which we were really encouraged about in a pretty short amount of time. And when you really dig in, what it seems like is some of those withdrawal behaviors were becoming less severe, and the ability to inhibit some of those socially inappropriate things were also becoming better for the intervention group. And we have other, so these are sort of the challenges based on the parents' report. We also have data from the young adult and their perspective on their own personal growth, which sort of shows similar patterns. So that's encouraging too. And I'm happy to talk more about the other data. I want to move quickly because I know we're mindful of time. That also, again, it's important if you're going to be doing an intervention or a treatment or a service for adults, well, all people, but particularly adults, they need to think it's valuable to them, and that is what we found. And that young adults on the spectrum reported learning many things from being in the group. Here you can see the list. I want to point out these aren't in any particular order, because we found it, depending on when you ask someone with autism what they learned, how they rank things and what seems to rise to the surface in their mind is most important shifts. So when we would ask the young adults what they were learning from being in the group sessions right away, like at the time we were doing the groups, they would really say things like employment, being independent, sort of those daily living skills or problem solving skills.
those were the things they talked about learning, which made sense. That's what we were working on in group. That was encouraging to us. When we waited to the end, till 6 months, where they had had time to kind of reflect and they weren't coming to group all the time anymore, the things they talked about were actually how much they appreciated being with other people on the spectrum in the group together and getting to know the other people in their group, as well as getting to know themselves. And so they would talk a lot about having some aha moments and this sort of sense of personal growth and development, which I think is interesting and something to think about. When we do intervention research, we need to think about a range of outcomes. At least in our sample we found for the individuals with autism, when they had more time to reflect, maybe what was most meaningful to them about the program was different with time. So here's some quotes. These are from the emerging adults. I've learned a lot about other people's experiences, other young people my age with autism, about how they cope with it, and about like daily life and getting jobs, keeping jobs. I've made a couple of friends through it. It really helped me a lot and taught a lot about other people with my condition. Next, the reason I got along with them is because we have a lot of the same issues and we can work together to fix them. I was the oldest one in the group and I've had a lot of experiences throughout my life. So being able to share my experiences with them made me feel better about myself. It truly did. And I know earlier we were talking about therapy often happens on an individual basis. I think this really shows the power of being able to have a group-based support because that connection came up again and again as the young adults had time to reflect. Parents also reflected, and things parents said that they learned were a little bit different. But anyway, I've learned how to help her better understand how her brain works. Really having it broken down and explained made us view her in a little different way. I'm learning to be more patient. I've realized that other kids have the exact same things going on as our daughter, and we thought it was just us. It was great to, this is another parent, it was great to meet other people going through similar kinds of issues. Having the bigger group for problem solving was good, since they had different experiences, and it would generate a lot of different ideas that you would never think of. So again, I think bringing parents together in a very heavily structured way to do problem solving, not just a not just a free-for-all to like say all the terrible things that are happening in life, but really a focus on looking for solutions also I think is valuable for parents. So to wrap up, we do think that this type of approach is valuable for adults on the spectrum and their families, and we're really excited to try to continue to do more analyses and to do this in a more diverse sample, and I mean diverse in a lot of different ways. We just have a little bit of funding to try to adapt this model for individuals on the spectrum who have intellectual disability and maybe minimally verbal. And so we're really excited to take this work in that direction. Also, I just want to make a shameless plug that we are doing a new type of model in partnership with Vanderbilt University around parent advocacy and for anyone ages 16 to 26 for parents. And there are no exclusions. So wherever you are on the spectrum, you are welcome to participate. So come see me and I can tell you more about that. So thank you. I know many of you have participated and I feel like you are my partners and co-researchers in this. And so thank you so much to the families and obviously our many collaborators at the Waisman Center. Thank you. And Teresa, do we have a minute for a question or should we wait for the panel? I don't know where Teresa is to tell me what to do next. Okay. Okay, so while the panel is coming up, I could field a question or two and then the panel is going to come, and I know the panel and James and I can answer questions too about our work.
All right. All right, we have a question down here in the front.
Do we know of any groups for teens and parents that meet regularly besides just research studies?
Yeah, so I would, this is why it's wonderful the Autism Society is co-sponsoring this event, so I know they're going to be talking a little bit about their program, and I know they have a table, so, and they do have activities, so, I don't even want to pretend to say what their programming is because I would misrepresent it, but I know that they do. That's a great question. Thank you.
We got one right here.
Sorry if I missed this earlier, but the Working Together program, this is an ongoing program? Are you still?
Oh, there you are.
Yeah,
Okay.
I'm right here, sorry.
I'm like, I can't find you. Okay, yes.
Are you still seeking participants in this program? Is this an ongoing thing?
So this is a,
Thank you.
it was a research-based program, and we are currently in the analysis place, so we're not recruiting actively for new participants, but we were hoping to. So maybe in another year or so, we would be enrolling more people again. So, and like I said, for this other program that would be more specific to parents, we're really needing people to sign up now. So, but that would just be for parents to participate for that one. Yeah. Hopefully soon. Thank you.
I just had a question about on the first presentation regarding anxiety and autism. You guys led off with a statement that there's a belief that anxiety is highly correlated in ASD, and then there was a percentage of 10 to 80%. I'm just sitting here pondering why don't, that is massive variety. Why don't we know better what that kind of number is, and can you make an educated guess today? Should I start over?
Is that for us? Oh, okay.
Yeah.
Yeah, I referenced the first presentation.
Yeah, sorry. Sorry, go ahead.
Yeah, I'm over here in the corner up against the wall. It was a question about the anxiety, people with ASD, and there's a belief that there's a high correlation. There was a reference to 10 to 80%. And I'm just sort of baffled by that variety. I'm wondering, is there any educated guess you can make, and are we trying to hone in on that a little better to really understand that?
Yeah, that's a really good question. So most people are estimating around 40%. So those, all of those studies are done in different ways. They use different methods of report, but most people feel like 40% is a good estimate. And yes, there is definitely a push to try to get a better idea of kind of the actual anxiety rate that we see, but also a better way to pick up those symptoms, because unfortunately there aren't standardized questionnaires or standardized things that are specific to individuals with autism. So that's one of the challenges, is kind of how is it diagnosed and how do you determine that? So there is definitely research in that area. I also do Fragile X research, and there is a big push in the Fragile X community to also better characterize those anxiety symptoms.
And just to follow up, if I can, how does that relate to the general population? And then as an employer, I wonder, when I look at the 200 people that work in my company, and I see my staff coming to me with challenges, how does that correlate to sort of the general population of working adults?
Yep, so when you look at general anxiety rates, it's about a little bit less than 20% is the estimate. So in the autism population, it's about twice as much as general population. Yeah.
A question I had was, there were certain types of different anxiety disorders. Is it common that there might be more than one applicable to one person?
Yeah, yes, it is very common if you have one anxiety disorder that you may have another. It is quite common. Okay, so we are transitioning into the clinician panel. Thank you so much for those great questions. So we have a few minutes. Again, my name is Martha Walter, and I'm a psychologist here, and I'm going to serve as the moderator. We have several questions that individuals have submitted to us either today or in advance that we'll be getting to as many as we can. I would, though, like for, I know you've met a couple, but you haven't met everyone, so I'd like for each person to be able to introduce themselves and their role.
James Lee, assistant professor in psychology and a Weissman investigator.
Danielle Scholze, I'm a developmental pediatrician here at Weissman.
Lisa Zerbakken, I am a treatment coordinator here with our Weissman Autism Treatment Program.
And I'm Amy Lyle, I'm a social worker and family navigator.
I'm Haley Crane, I'm a psychologist. I work in the Autism and Developmental Disabilities Clinic. I also work in our newborn follow-up clinic, and then work on the research side in the clinical translational core.
Thank you. So our first question has a few different parts, and I'm happy to repeat any of these, but I'll read all of them if that's okay. So the questions are, who is all on your multidisciplinary diagnostic team for making an autism diagnosis? Can you tell us what the process is? Does the patient meet with each discipline individually or as a group? Who makes the final autism diagnosis determination after each individual discipline completes their part of the assessment process?
So this is a really great question, and the process starts from a referral from an individual's primary care provider, and that referral then goes to our triage team, which is made up of our clinic coordinator, who is Paula Perez, and our clinic director, which is Lindsay McCary. And sometimes the referral question is not always clear, so they might ask one of the family navigators, and I'm one of those folks, to reach out to a family to learn more about what the concerns are. So sometimes people get a call from us on that end just to learn more about what the questions are. The triage team are the ones that make the decision about who it makes the most sense for a family to see for an initial visit. Some families come for multiple visits to the Wasteman Center, and I'll let Dr. Crane talk a little bit more about that. Before the initial visit, we make an effort to reach out to every family. The family navigation team makes what's called a pre-visit phone call to learn from the family's perspective what their major concerns are, what their questions are, help them know what to expect the day of the appointment, how to best prepare their kiddo, and listen to any concerns that they might have about even just the day of what to expect. Then family navigation is available throughout the process, both during the diagnostics and then after, to make sure that families are connecting to the services and supports that they're looking for and that might be recommended.
And I think Amy touched on something really important, is that through our diagnostic process, we want to make sure that we're really individualizing it for the individual that's coming in. So not every child's going to receive the exact same process. Because we're able to have family navigation call and get information on them, we want to really make sure that we're addressing their unique needs. And so our multidisciplinary team includes audiology, occupational therapy, speech-language pathologists, developmental pediatricians, psychologists, and social workers. And so we really look at it as a team approach that we're able to, depending on the needs of the individual, then they're given an appointment slot with the provider that best fits the question that they're asking. And many times then, I think the last question was, who gives that final diagnosis? That's typically a developmental pediatrician or a psychologist that then will be able to provide feedback. The really nice thing is that we have family navigation embedded in our clinic. So on that last visit, we really want to spend time talking to the family, giving them resources, talking about the diagnosis so that we can support them so that they can go on to that next step.
And I think just one follow-up note is that many families may meet with individual providers alone, but we do have some combined visits. So depending on who's coming and what is most helpful or seems to meet the needs best, there are some combined visits. So for example, I have a combined visit with speech and language, which is wonderful. So it's psychology and speech and language. Dr. Crane has a combined visit with a developmental pediatrician. And so there's some variability and flexibility in terms of what we can offer. And what it's really, again, I think to echo, based on what seems like it will be most helpful for the individual person and family. Okay. All right. So our next question is, how do you determine which treatment goals to address first? Do you have a specific treatment you subscribe to or would recommend we learn more about?
Hi, so I can speak to our Starting Together treatment program here at Weissman. The first steps in deciding what treatment goals will be appropriate for your child is you will meet with our providers. So our providers are board certified behavior analysts, myself included, and we also have a social worker on staff. So you'll meet with the providers, we talk with the parents, in any of our Growing Together programs, the individual client receiving the treatment may also be included in those the treatment development of those goals, depending on their functioning level. And within our program, we will decide with parents as well as using a variety of developmental assessments to determine which goals are going to be appropriate for the child. In our Starting Together program, we use the Early Start Denver model, and that also contributes to the treatment goals that we decided with the family. It's highly individualized and dependent on each child and each family and what's really the most meaningful to that family of what they want to work on for their child. Is there another part?
I think you touched on them, but just do you have a specific treatment you subscribe to or treatments you'd recommend we learn more about?
So here at our Starting Together program, we follow the Early Start Denver model. There are a variety of treatment models out there, and there's not one specific treatment model that's going to work best for each child. So you're really going to have to work with the providers in your child's life to determine which is going to be the best treatment model that works for our child. Early Start Denver model is a more naturalistic approach to autism treatment and still uses the principles of applied behavior analysis along with that. Really, if you're looking to determine what's the best fit for your family, is working with your pediatricians, your social workers, everyone on your child's treatment planning team, as well as board certified behavior analysts.
Our next question is, are there any links between excessive or increased electronics usage and increased ADHD symptoms?
Okay. The first thing I'll say is correlation does not equal causation. And so while there might be some cases where we've seen a relationship between increase in technology usage or watching television and maybe more inattention or hyperactivity symptoms, it may not be a necessary cause of those symptoms. The research around technology and media consumption and ADHD is, I would say, not very well established right now in terms of leading us to any one conclusive, definitive statement that we can make about it. And in fact, what I will also say, and maybe some of the clinicians on this panel can support this, is that technology and media consumption might actually be beneficial in some cases with children with ADHD, that it can be quite useful as a tool to encourage positive behaviors. And by limiting the consumption of certain things like their iPad usage or video games, that could actually turn things back and make things a little worse in some cases. So I would definitely caution against going too far in one direction based on anecdotal evidence that all media consumption and technology usage is bad. Certainly there could be cases in which it may not be beneficial for a child who already struggles with attention, but in many cases, in some cases clinically, children with ADHD can respond quite well if you give them a structured time with which they can use their media devices, and it could eventually even lead to better outcomes in other domains of their behavior. So not one way or the other, and I think the research isn't very clear anyways.
Does anyone else want to comment on that? Or?
No, exactly the same thing. I mean, I don't think we really know, but definitely the correlation versus causation is huge. There's so many times that people talk about a correlation and this is associated with this, and that does not mean it's a causative thing. You can pretty much find a correlation between just about anything if you really try. So we really want to be very careful about how we interpret those studies, but the research really isn't there yet.
So I think we have time for at least one more question, which has two parts. So how common is it for those with anxiety to also have ADHD? And how are these individuals treated if stimulants can negatively impact those with anxiety, but stimulants positively impact ADHD?
That is a really good question. First of all, it is really common for people with ADHD to also have anxiety, and vice versa, people with anxiety also to have ADHD. I kind of always laugh. My son has the AAA, that's what I call it. So my son has autism, anxiety, and ADHD, and I feel like, it's like there's so many people out there that also have that experience of having a child or being an adult who has all of those things. So yes, we see it a lot. There is also a lot of question as to whether, what comes first and what leads to what. So there are definitely a lot of thoughts about, does ADHD lead to anxiety due to the environmental stressors and behaviors? And I do think that's a huge contributor. So I think that oftentimes kids may start off with ADHD but later develop anxiety just because there's so much pressure and so much stress. And so I think, there's that huge overlap. So yes, it's a huge challenge. When it comes to treating with medication, we still do typically try stimulants first. So usually that's where I start with. I always also very much think about what is causing the most impact. So if a child has both anxiety and ADHD, I'm gonna spend some time trying to delve into which one is really causing more problems. Sometimes it's not the ADHD that's causing significant challenges. Sometimes the anxiety is the bigger problem. And if that's the case, I'm gonna go for treating the anxiety over the ADHD. So I typically do try stimulants. There are different ones that may be better tolerated in some kids, so sometimes I'll choose specific stimulants, but there are alternative medications for ADHD. Alpha agonists, so a lot of people have heard of guanfacine and clonidine. Those medications can be used for ADHD and don't tend to exacerbate anxiety. They're not used specifically typically to treat anxiety, but they can be a good option. Strattera is another one that sometimes is used. There's some questions as to how well that works in patients with autism, but that being said, I have had some good luck with Strattera, which is another non-stimulant treatment for ADHD that doesn't tend to exacerbate the anxiety. So that's usually my go-to.
So we are going to transition now to our next panel. Thank you so much.
Hi everybody, I'm Nancy Alar. I'm president of the Autism Society of South Central Wisconsin, and I'm moderator of our panel of experts today. I want to thank Dr. Chung and all the other staff of the Wiseman Center, especially Teresa Palumbo, for helping me set the panel together today and for setting this up. And thanks everybody for your attendance, and I'm sure that we're going to get some really great information from our panel today. Our panel members, their little bio is in your program. I'm going to just introduce them by name. They have their name tags in front of them, but you can read their bio on each individual. There's from my left to right here is Jennifer Moore and Clyde Fruits and Jack Steinberg and Kevin Thayer and Layla Thayer. Michael Thayer is not with us today, but he is the fraternal twin of Kevin, and Kevin and Michael are both children of Layla. So that's our panel member today. And I just wanted to commend everybody for managing your anxiety about the parking today. And also to the Wiseman staff for managing their anxiety about the timing of everything today. We do have a list of prepared questions that I'm going to go over with the panel. And the panel members have their instructions that they can pass on any question, and they're going to be passing microphones back and forth. So it's part of the logistics of this. And they're going to be answering these questions, and if we run out of time and before we run out of questions, we may take some questions from, if we run out of questions before we run out of time, we may take some questions from the audience. So we're going to start with Jennifer, and the first question is, how did you find out that your child was on the autism spectrum? And if the person is on the autism spectrum, the question for them is, how did you find out you were on the autism spectrum? So, Jennifer?
Thanks, Nancy. So when my son was in the 1 to 2 year old room at his child care center, the teachers started to notice that something was a little different. He wasn't communicating with the other kids and kind of hitting occasionally. And they were great because they said, maybe he can't hear. And so that kind of began a journey of trying to narrow down what was going on. And then we went through some birth to 3 services who finally said, you know, I don't know that this is a speech issue. You might ought to get an autism assessment. And so we were able to work with a provider to do the autism assessment. And so he was formally diagnosed when he was about 2.5. And so that's kind of how we found out.
I want to thank everybody. Well, way that I found out that I was on the autism spectrum. My mom used to work for the Autism Society, and when I was 7, I went to the office with her, and I looked at the sign, and I told her, "You work for the Autism Society?" And she said, "Yes, I do." And then I asked her, "Do I have autism?" And she won't prepare for that question. She wasn't prepared. But anyways, I've been very excited because now with Mom, I finally get even more knowledge about all my autism out of her, and I hold so many events. What I really like is to just get the word about autism out there, and that's how I found out I was on the spectrum.
Okay, thank you to everybody. I found out, I mean, I had some services when I was in school and stuff. I didn't really know what they were for, but I really finally found out I was on the autism spectrum, actually, through searching Facebook for some groups regarding Asperger's, and kind of realized I lined up with the symptoms, and that was really how I kind of found my way in eventually to the Autism Society and realized I fit in with that group, and that was basically a self-diagnosis.
So my twin brother and I, Michael, we were both diagnosed, I think around the age of 2. Received an educational diagnosis through the school, received services. When I was, I think, maybe 11 and in 6th grade is when I really realized that I was also on the spectrum, that I had, an Asperger's syndrome disorder, but that it really affected me. So we've been receiving services, educational and other services ever since then, until I found out.
I think it would be best if we hold our applause till the end because we don't have a whole lot of time here.
Yeah, so Kevin kind of touched on it, but having twins, there were some delays kind of early on, and some, looking back, some mannerisms that were sort of unusual around the age of 1 to 2, but nothing that stood out drastically. But around age 3, Michael, Kevin's brother, had some more sort of noticeable mannerisms that were concerning, and my husband looked it up online and kind of pointed us in the direction of autism. So I, at that point, contacted the school district, and they came out and did the early childhood, or the assessments, and they both qualified for early childhood. So that was about age 3.5. And then Michael, we pursued a medical diagnosis about age 4.5 through Katie Beckett. And then both boys had IEPs all through school.
Thanks, Layla. Back to Jennifer. What are your most important memories of you or your child being in school?
Okay, so my son is in 1st grade right now. So we're still pretty new to the elementary school thing. And I think one of the things that stands out to me is last year in kindergarten, they were working on a program for the end of the year, a kindergarten song. And, oh boy, here we go. All right, so I just get a little emotional when I think of all these really good things that people have done. So he has high support needs, and so he has a one-on-one aide with him all day from the minute he gets off of the school bus. Actually, he has an assistant on the bus as well. But they put together a program, and he had been practicing right along with the class, and when we got to the gym, he was like, wait a minute, this is evening. I don't belong at school at night. I don't want to go in here. But he wasn't pushing and saying go car, which is our signal that it's time to stop and leave where we're at. So he kind of pushed through with the aid, and I got to sit with him in front of the auditorium of parents, and he performed right along with the class. And it was such a beautiful thing to watch him just be a part of the group and do what he could do with the group, and everybody really enjoyed it. And I think that's probably been one of my favorite memories so far in our short time with our elementary school.
I think one of my memories that I've had being in school so far and just being a sixth grader, that when I was younger, I really thought of myself as not having really that many friends, always feeling left out, lonely. And then when I got good news that I was one of the football managers, that just opened up the door for me, and now I'm even more connected. So football's really helped me a lot within my life, and it's just been a big influence on me.
I always consider myself fairly fortunate that I was lucky enough to go to Lincoln Elementary here in Madison, and they had really excellent teachers, and they really helped them keep things under control, so I wasn't teased as much. I mean, I still had some of the teasing and outcast stuff, but less than a lot of the other people, and I really felt like it was a place I belonged, felt safe and comfortable, which was really important, I thought.
Yeah, so I received strong school services, was able to, school situations were good, got a lot of support, just through schools. I always felt like it was a little bit, awkward, just maybe a little bit shy, included just socially, wasn't as connected to the other students as I would have liked to be, but I didn't mind as much. I was a little bit set apart, but, I received good school services. I was able to generally do well in school. I was able to connect to other students, and especially when I got to high school and things really got difficult academically and socially, I received a lot of school services through the Madison district, which were able to help with that, so it's important.
Yeah, so speaking for Michael, there were some good years, some not so good years. I think generally the people working with him had the best intentions, and he could be challenging with some of his behaviors and kind of day to day. As far as memories, I'd say the most interesting thing, Michael is 20, and he talks so much about those early years of going back to preschool. He remembers the names, he remembers specifics, he remembers exact things teachers told him, and a lot of it he didn't tell me at the time, but now he's telling me things that happened 15, 16 years ago, and I'm thinking, some of the stories aren't the best. I mean, in terms of the interaction, maybe things could have gone a little better from the staff perspective, but it's just interesting how clear all that is to him after all this time. So overall, I think it's been a good experience, and certainly stands out to him above most other things in his life.
Thanks. So back to Jennifer. What is one thing you would like to tell teachers or school personnel?
I think for me it would be when you're caring about your student. We've been very, very lucky. We've had great experiences so far. And I think part of the reason for that is because we've had caring teachers that look at the challenges that my son is having, and they continually look for alternatives and other ways to support him. So, they found that in gym class, he wouldn't sit to listen through instructions, but he loves to run. So his assistant said, well, what we're going to do is we're going to run laps in the gym until he's tired. And then he runs and he runs, and then he sits with the class and is able to participate. So it's just enough of what he needs to be able to do that. They found an alternate reading program that would work with his AAC device, using his AAC device in him to help him learn to read his sight words. And it's been phenomenal to watch that, because then he's also developing verbal skills to go with that. So I think I would just say, get to know your students and find those other ways and other avenues to help support them when what you're doing doesn't seem to maybe be the best approach for their particular learning method?
Well, definitely one thing that I would tell teachers or schools is that make sure that your student feels like they belong here. I know that people with autism get bullied more than regular kids do. So even though people with autism may look like different people, they are really just the same as us. They are unique humans who just want to feel like they're part of the group. So what I would say, always include, never exclude anybody.
To expand a little bit actually on what Clyde said, I would also say make sure the other kids get training on, being nice and inclusive to people with disabilities and autism specifically, but also other disabilities. A lot of times the other kids don't realize that, maybe this person can't help their behavior and they have to behave that way, and that's not fair to bully them or outcast them just for that. So I think that's
yeah, and just that everyone on the spectrum is different. That it can be very subtle. These kids are often trying, but just to be kind to them, to accept them, and realize that struggling with every day, even just little things like social interactions, different things in school, academically that could be stressing them out. Like in my case, just being kind, including them, recognizing that each person is different, that they may have subtle characteristics that they still have autism. Just being able to include them and just accepting them for whatever the situation is that you find themselves in with them is important.
Yeah, and this, for Michael, I think would be more directed at the staff. And again, I think everyone has the best intentions, and they wouldn't be going into special ed if they didn't really care about helping people. So I don't want to be critical of the teachers and the aides. But I think sometimes when the student is variable, as Michael is very inconsistent in what he can do from day to day, and some days energy up, some days down, mood fluctuations, anxiety up and down, it's very challenging. So there's some days he just can't really do that much. And I think just kind of reducing expectations and kind of just giving them the space that, yes, the IEP goals are great. Sometimes he can do it. Sometimes he absolutely can't. And it's not intentional. And it's not being willful or difficult. It's just he cannot do it at that time. So I think just being cognizant of that would be helpful.
Okay, next question. Kind of related to some of your earlier answers. What has been your personal experience with bullying?
We're still new enough at it, and with my son having an aide, I don't believe we have experienced that yet, but I definitely worry about that because I am anticipating at some point it is going to be something that we're going to experience and have to learn how to deal with.
For what I know, I myself haven't really actually had any bully problems with myself, but I can remember one time that out in 3rd grade I was playing flag football with some of my friends, and then another kid that I know who has autism, he wanted to join, but the other kids really excluded him, so I had to stand up. I gave him a chance. What I think that really bullying, it's not right. People with autism deserve to be treated like everybody else. That's just one of the key things that I worry about with people with autism.
I actually have had both extremes of the spectrum of bullying, and that I was fortunate at Lincoln that they had an absolute no tolerance for bullies, and they were the staff would come in right away and stop anything from happening, and it really made a very positive experience. But then for 6th grade, I went off to the brand new Wright Middle School when it first came into experience, and they didn't yet have a discipline policy or curriculum or anything in place, and so bullying was everywhere, and I didn't feel safe. And it's just amazing how the different extremes can be, go from a very positive experience to a very negative experience that was hard to recover from.
Yeah, I can't say that I've experienced bullying a whole lot to the extent that probably a lot of other kids have. I have felt socially awkward, just socially kind of set apart, but I didn't mind as much for a while. Bullying hasn't been as big of an issue for me, but it certainly has been prevalent. It's something that the teachers and the staff have tried to work around, but just being important and just treating everyone the same and just intervening when that can be difficult is important.
For his brother Michael, since he was in more special ed and kind of self-contained, not as much in the regular classroom, Kevin was always fully mainstreamed. So Kevin was kind of more in the mix, having to deal with without as much help. I think Michael was kind of off limits more, so he's somewhat protected by staff. So there were some incidents, not too bad, but just one point I wanted to make, just hearing others on the panel, is sometimes bullying can be very subtle, not just the words or even physical incidents, but I think even feeling excluded and that there's something wrong with you and you don't belong. I think that also constitutes a form of bullying, and I think that's something that is very widespread and a big problem.
Hey, this next question is sort of a two-part and a little bit complicated, so I'll try to read it carefully. As a parent or family member, what kind of behaviors by people on the spectrum do you find challenging, and how do you deal with it? And if you're a person on the spectrum, what kind of behaviors by people who are not on the spectrum do you find challenging? And how do you deal with it?
Okay, so Nancy, you've explained that question twice, and I'm still probably going to answer this in a very completely different way than what you intended. So when I think about the question, and I certainly think about some of the behaviors, which depending on, whether it's right now or it was, in the recent past, we've had different challenging behaviors. When I was thinking about the question, I was really thinking about myself and my husband and how we respond to my son. And so I find it challenging for myself and for my husband when I watch him, where my son will be upset about something or reacting in a way that is not typical for us, and we sometimes find it challenging to adjust our responses to that. And so, when we respond as if he were typical, that normally does not go well at all. But when we stop and take a breath and go, okay, wait a minute, this style is not working, let's try something different that maybe feels awkward for us, that tends to be better for him. And so I think the challenge we have is continuing to check ourselves and how we're reacting to him and trying to support him.
As being someone on the spectrum, I find definitely some of my behaviors to be very challenging. Like, if I'm playing like a little game of badminton with my brother, I might always hit the ball. I might always hit the birdie very hard, and he'll sometimes get very upset, and he'll tell me repeatedly to hit it softer, and sometimes I just won't do it. So, like, if I'm dealing with that kind of situation, soon I will normally cope with that situation, and then everything will be fine. Whenever I'm worrying about some sort of like, for example, if I'm going on a vacation and my mom tells me there's something dangerous in that place where we're going on vacation, I might normally stress out to the days leading up to the vacation, just worrying myself to death. So what we really try to do is really just forget about it all, just focus on right now. And my mom will tell me that she's just going to keep me safe no matter what. And sometimes everything that we always bring to make me comfortable is headphones. So my mom will always do stuff to help make me comfortable.
As someone on the spectrum, for me, I think I find going to new social situations or places I haven't been alone can be very challenging. I can feel very awkward and like I don't know what to do or how I should be behaving per se in that situation. And that can be a challenge. Sometimes, you know, the more I do it, the more comfortable I've gotten, I think is pretty much how it's been.
Yeah, I agree. As someone on the spectrum, it can be very difficult to adjust to new social experiences. For example, being away at the college environment can be difficult to just interact and really kind of find a place among kind of new social surroundings. I just find it really difficult too, especially with school and with just different interactions with other people. Some nonverbal cues like, you know, eye contact or, you know, the way that I'm communicating, little subtle things like that. I can find it really difficult to effectively communicate and bridge the gap between people sometimes. And, you know, sometimes I wish, you know, typical people could be more understanding, but, you know, it can be a communication gap, and just being able to bridge the gap, it's important to just interact and be understanding, be cognizant of whatever difficulties the person might be going through in day-to-day life, and being able to interact with them effectively regardless is important.
For Michael, his brother has had a lot of mental health challenges, a lot of anxiety, and again, a lot of inconsistency where some days he's very sociable and wants to talk to us all the time and everything's fine, he's in a great mood, and other times it's leave him alone, he doesn't want us to talk to him. It can be very difficult figuring out how best to meet his needs. I almost think we have to kind of be mind readers because there's a lot of kind of intuition, and we don't always get it right because he may say something, he wants something, and then he reverses himself, and you can really go down a really stressful path. So it can be really challenging. We do the best we can to meet his needs and try to keep things relatively calm, sometimes more successfully than others, and it's had an impact on Kevin too. So for all of us, it's interesting. Okay, back to Jennifer. What are your experiences or concerns about transition to adulthood?
Oh, well, we're 7 right now, and and I think while I definitely think about it, one of the things that I learned early on, and this is maybe going to sound a little weird, when my son was first diagnosed, it was very difficult to picture what he would look like older, right? So at 2.5, he's wandering around the room, he's not got spoken language, and, you know, doesn't look like he's able to pay attention to anything. And in my mind back then, I'm like, oh my gosh, is this what 17 is going to look like? Is this what 30 is going to look like, right? And then you take a breath, and then time goes by, and you go, oh my gosh, you know, 7 looks nothing like 6.5, looks definitely nothing like 2.5. And so I think for me that helped, because at 17 or 35, we're going to look very different than we do right now. I also feel fortunate that, you know, families like Lila and others who are farther along in this journey, the world is a very different place for our autistic loved ones, not where it needs to be by any means, but it's definitely, I think, there's progress there, right? And so by the time we get there, it's going to look a little different than it does now, I guess. So I worry about it, but I'm trying not to worry too much.
Definitely, I am really always getting some concerns now that I'm in 6th grade. Now I'm starting to get more homework, and I know that we're all really busy. I'm just all distracted by TV, and I can't find the time that I need to get all that done. So basically what I'm doing, starting yesterday, I created a little homework list so that I can focus on that list so I can manage my homework easier. But I'm always worried about, like, when I'm an adult, independent, how will I handle myself, like that kind of stuff. So not too much concerns really right now.
Well, better off than I was at that age. For me, my biggest challenges was I was pretty much mainstream through school. My parents very wisely tried to encourage me to do as much as I could, and it was great. And then I went off to college, which is a logical next step, but I didn't realize that I was going to have social trouble because I'd kind of not had I never had moved, never had the experience of being in a new location, trying to make new friends, and that was really where I struggled when I had to, go in this whole new environment and nobody was around, and I had to come up with new friends in the adult world, and that was really my biggest concern with the issue.
Yes, similarly, I was mainstreamed. I was mainstreamed all through the school environment, through school, but I've had a lot of issues, a lot of difficulties, especially once I got to high school, with stress, with academics, and with the extent of schoolwork and the stress that was able to have on me. So, and socially, I've had a lot of challenges with that too, going on to college. So after high school, I started off the fall semester at UW Whitewater, but have opted, was there for a year and a half, but have opted to take the next semester off. So just being worried about school and social things, just being able to be independent and successful, in terms of a job in the future, and just being able to do something with a sense of purpose. That's kind of what I worry about going into adulthood.
Yeah, so I guess for us then it would be two kind of different paths, kind of helping Kevin along, and then Michael, who needs a lot more support. So kind of the usual long-term goals: where will he live? Will he be with us? Who will help take care of him down the road? And so just a lot of questions. And I try not to look too far into the future because there's a lot to be determined. And thankfully, a lot of services and a lot of support. But there are, of course, the usual long-term worries we all have as parents and people on the spectrum.
Okay, next question. Who or what provides you with support in your life?
We have a really wonderful village of friends. We just have to remember to ask, and asking for support, I think, is a big challenge for us. We have a tendency to think we got this, we can do this on our own, and they're more than willing to help out. You've just got to say, okay, yep, I need it now.
I think the people who help me provide the most support in life are probably my good friends, my friends at my school, because whenever I'm right by them, I'm always feeling comfortable. I feel like I always fit in. But I think the most greatest supporter probably is my mom. She has really given me all of her knowledge on autism, and with her taking me to special autism events, I've kind of grown now with the genetic disorder, and it's like a miracle. It's like a miracle from God.
I've been fortunate to be fairly independent in my life, but I still do rely on some support. I mean, my family, my parents particularly, live real close to me, which has been nice. But also, especially in recent years, I've been involved with the Autism Society of South Central Wisconsin and another group of people with disabilities here in Madison called Love Inc. And they both, through their social groups, have helped support me also, which has really been nice. And of course, I'm employed, and my employer has been very supportive too.
So I've had a lot of support with family. Parents have always been really an essential source of support. Also helped through the school. I was fully mainstreamed, but especially once I got to high school, had tremendous difficulty with academic stress and with other social and mental health challenges. So having a case manager to help me through that was really invaluable. going into college, also having a disability support counselor has been very helpful, as well as just having other friends, other people I could talk to, and other like counseling and social groups. Some that are targeted towards autism, as well as the family, have been important sources of support for me.
Yeah, I think family is key. We don't have any extended family in Madison, so it's just our family. But just having friends, people to talk to, people whose children have autism and some who don't, just kind of getting a balance. And Autism Society, some of the events, just to feel that there are people to talk to who have been through maybe not exactly the same situation, but similar, and they can point you in the right direction for resources. I think that all is crucial. Okay, next question. What is one thing about your experience with autism that you would like to share with our audience?
Meet and listen to autistic individuals. It was one of the best things I think I could have done early on. Being able to be a part of this panel and listen to the experiences of Clyde and Jack and Kevin. Lila and I actually were years ago at a couple of Moms Nights Out hosted by the Autism Society, which were great for me to not feel alone and to hear their experiences. And 9 months into the official journey, I had an opportunity to attend a conference and hear autistic presenters. And for somebody who had not had a lot of connections, to my knowledge, with folks that were on the spectrum, it was a really great experience to be able to hear from. There was some twins there that talked about how they had not had verbal communication skills and they were now in college, and they shared their journey, and being able to see their experiences and where they've gone, it made a big difference. Now I search out groups where I can learn more from autistics and get their perspective, because while I know my son, I don't know what it's like to experience the world the way he does, and we think about things a little bit differently. So,
one thing about my good experience with autism, that having autism is excellent and a little bit bad. Why I say it's excellent is because with this kind of skill, now I can do things that other people really do find hard, like definitely music, art, math, etc., etc., etc. But why I say it's kind of bad is that you have to go and get on all these, you have to really put in a lot of your time going to therapy. You have to really work out what you like and you don't like. You have to find ways to really get involved. You have to take time off classes. But overall, it's a great blessing.
One thing about my experience is that it does not have to limit your potential, what you can do. I mean, anybody can do anything. Being on the spectrum doesn't, stop me from doing what I want to do. It might have been a little harder to get there, but I can still live a fulfilling life and literally be whoever I want to and do whatever I want.
And again, just that it affects everybody differently, manifests different symptoms. There may be some common symptoms, but it can be very subtle, and that for the most part, I think everyone with autism is trying, they're doing what they can to really be successful and try to integrate into the community, interact with other people, be successful in the work world, etc. So, I mean, again, just being cognizant of the differences and just supporting them, being kind around them is, probably just the most important, way to ensure their success going forward in the long run.
Yeah, I would say it's easy as a parent to become isolated sometimes, especially in the early years when you don't know a lot of people and you're kind of just dealing with the day-to-day, and even just the diagnosis part of it can be difficult, just because even if you were expecting it, you have to kind of change your expectations for the long term, and it's easy to just kind of close in and not really reach out to people because it seems you don't have the energy for all the other things. But over time, I do think it's really essential to develop some network of support, people you can talk to. And don't always have to talk about autism. It's, I think, also good to have other interests and other things in your life besides dealing with disability and problems. But I think just trying to reach out to people when you need it, and again, also have your own interests and things that are meaningful to you. Okay, thanks. Next question. What situation or situations cause you anxiety, and how do you cope with that?
Okay, so as I mentioned, my son loves to run. He's super fast. So for us, probably one of the bigger things that causes me anxiety is when we're out, especially if it's somewhere that we haven't already developed a really strong routine and habit with how we engage in that event. I'm always on edge because you never know when he's going to take off, and you got to catch him quick. And because he loves to run, when you start to chase, he goes faster. So, and you know, and I think kind of in line with that, the other piece of that is the looks and my perceived judgment of everybody else around us, and that I think has been one of the other things that's harder to cope with. Is, you know, how do you just let that roll off and be like, oh, well, whatever. I know I look like I'm a bad parent because I'm not running them down, but if I do, it's going to get worse. And trying to like cope with that for myself is sometimes hard. You know, we had a situation where he just completely lost it in a children's museum up in Baraboo, and all of these adults are just looking on, and I felt myself getting so anxious, and then instead of responding to what he needed and just being worried about him, I found myself falling into that trap of, oh my gosh, these people are looking at us, you know, you've got to stop, you've got to put that stuff up, and it made it worse. And then when I left, not only did I feel bad, then I was like, okay, wait, you know better than this. You know that you shouldn't have worried about what all of those other people were thinking. And so that's something I continue to work on. Some days I'm much better at it than others. That was not one of those moments, but so that, I think the running and then just kind of the other people's perceptions of us is where some of my anxiety lies.
Well, definitely lots of situations can cause me anxiety. Like I mentioned earlier, going to a place and then my mom mentions something dangerous and then I scare myself to death. Through the days leading up to the trip, I'm always forgetting about it and just focusing on what I have to do. But another one of the things that really does cause me anxiety is sometimes loud noises like monster trucks, like stuff like that. So like I mentioned earlier, we always bring headphones for that kind of case. And I remember that I was little, I used to absolutely hate going to the circus, and I was always scared when they would do the cannon. So I would go right up to my mom and we would do a little cuddle thing, and we still do that today. So those are some of the things that really do help me cope with all my anxiety that I really have today.
Dare I say that I get anxiety from being on a panel for the first time ever? Other than that, any sort of new or uncomfortable situation for me can give me anxiety. How do I cope with it? I try to think ahead and try to plan ahead, think about what I might experience while I'm there, and or like where I'm going to go when I first get there. And that tends to calm me down. And deep breathing a little bit also helps, just working through it basically.
Yeah, I have had a lot of school-related anxiety, especially going back to high school. You know, I'd always considered myself a good student before, but you know, the extreme demands of the new high school environment, the honors classes became really difficult. So, just being able to cope with even day-to-day demands like that with school and just other demands has been stressful. But just kind of being able to make a plan, being able to work through it, and allow time for other things has been important. I have a lot of social anxiety too in a new environment. Day to day going somewhere. I'm at college and I worry about how someone is going to perceive me. So just, you know, trying to communicate clearly, not be awkward. Just trying not to worry too much, prepare in advance, and just know that whatever is going to come, just be okay with it. Kind of allow time for other things too is important.
Yeah, as far as my own anxiety, Jennifer, I could really relate to the public meltdown. We went through a lot of that with Michael. There were a bunch of times around age, 2 to 4, where, I mean, my husband would literally have to carry him out from a public place. We'd bring him to a zoo or some place that was supposed to be fun and relaxing, and he would get overstimulated, and it was really difficult. We had to kind of scale back and stop doing things as much. So I can relate to those days. But now I would say, related to Michael, it would be more along the lines of when I see him escalate and I get nervous, wondering how am I going to handle it in the moment, because it's so variable, and just trying to figure out how can I quickly nip this in the bud. Strategies don't always work for him, and they may work one day and not work another day. So again, just kind of tiptoeing around and trying to kind of work through those day-to-day issues can be anxiety provoking, dealing with it.
Okay, we're getting close to the end of our time here. And I'm going to ask one last question, which I will remind the panel that they can pass if they don't want to answer this. Have you had any experience with dating? If so, how did it go?
I believe that's intended for the gentleman in the middle here.
Oh, man.
For what I definitely know, pass.
Okay. I have, and it started out when I was in high school. I had a couple of relationships that I just wasn't ready for, and one unfortunately kind of took advantage of me, and it didn't go well. And then I went for 13 years without anything, and really got kind of lonely and desperate, and which unfortunately also, when you're desperate, can lead to things that aren't so good. The good news, the silver lining, that I went through all that, and eventually I, ended up with somebody who I was friends with for probably 3 years before we started dating, and it's so far been working out really well. And she's here in the auditorium, so it's been a good experience on that one. So that's my experience.
Yeah, I do not have personal experience with dating. It's always been something that, I've been a little socially awkward or struggled to make friends or meet people. It would be hard for me to connect with someone in that way, but I do hope to, down the line, to be able to make that connection and hopefully long term find happiness with someone in that way.
Layla, do you want to try to answer that question at all? Or no?
Well, there's nothing for Michael to really share, so.
Okay, all right. Well, that's all the questions we're going to ask the panel. Is Teresa here? What? Okay, I just wanted to summarize. I was Jack mentioned that autism does not have to limit your potential. I wanted to really second that, and my connection to the Wiseman Center is also personal, and I wanted to add my thanks to this organization, the Wiseman Center, because My son, who is also on the autism spectrum, is now 41 years old. He was diagnosed here when he was 2, and he went to their daycare center for a number of years, starting when he was 2, and they were extremely helpful. We've had a long association here with the research studies, and he is now 41, as I mentioned, and he became the first person they ever knew of with a full-blown autism diagnosis to ever graduate from the UW-Madison. So, yeah. So do not sell the people in your lives short with autism, because they will accomplish things that you would never believe. So thank you all for coming today. It's been wonderful. Really appreciated the speakers.